It looks like we are live, ma'am.
All right, good morning. Welcome to the second day of the Labor, Health, and Social Services Joint Interim Meeting. Today on the agenda, we've got a lot of presentations on mental health. That's the main focus of the day. And we'll take general public comment on Labor Committee topics at the end. I don't believe we have to take the roll because we really just recessed from yesterday. So do we have, LSO, is there anything we need to know about before we put on our first presenter, who I suppose would be Jeremiah Riemann, or maybe someone else filling in for him? I guess not. Who have we got?
Ma'am, we have let Mr. Riemann into the meeting.
Awesome. Good morning, Jeremiah.
Good morning, Madam Chairwoman.
Do you have a presentation for us on the suicide prevention grants?
So, Madam Chairwoman, I appreciate the opportunity to speak to the committee today. I actually have worked with Commissioner Natalia Macker from Teton County to provide some comments this morning, and I believe she's just being connected in right now. So I will actually turn it over to her.
Okay. And Elizabeth, did we get a PowerPoint or anything on this, or is she just going to tell us?
Madam Chairwoman, we have no presentation for
That's fine.
Verbal comment.
We just like to line them up if we have one. So
right. So,
Commissioner Macker, welcome.
Good morning. Thank you, Madam Chairwoman.
Thank you for showing up. We would like to hear. So for the committee's information, I put this, or Chairman Scott and I put this on the agenda because a couple of years ago, maybe 3 years ago, 4 years ago, in the course of JAC's work, a budget footnote basically routed the suicide prevention grants through the county commissioners rather than through the prevention management organization process that had been in existence for a little while before that. And it seemed to me that we ought to take a look and see how that was working, make sure that the counties were getting the prevention services that we hoped that they were getting. And so I just asked the county commissioners, and I believe we'll have a few other presenters on this as well. I don't have a specific plan in mind because I don't have the information yet. So that's sort of my intro. Go ahead, Commissioner.
Thank you. Thank you for the opportunity to be here this morning. As I think we are all aware of the sobering statistics around suicide, but just to remind us that Wyoming has the second highest suicide rate in the United States, and it's one of the leading causes of preventable death in Wyoming. So we are pleased to share that the move to a county-based prevention coalition model has, in our view, been a positive evolution of suicide prevention efforts in Wyoming. Since the program shifted, counties have had the opportunity to work with the Department of Health to stand up programming in all 23 counties to directly provide suicide prevention activities in a collaborative and responsive manner through this coalition model. While admittedly there were some hurdles at the beginning in establishing it, we have had a positive relationship with the Department of Health, and the association has worked consistently with the Department of Health to evolve the program in each county. As it is now established in counties, we are seeing communities work together to leverage resources and to respond to the changing dynamics within their individual communities. And we believe that this framework will grow more efficient and effective over time. The coalition model being deployed brings a broad base of community organizations and individuals together to work towards suicide prevention efforts using evidence-based strategies. Coalitions are made up of diverse representation, including the business sector, healthcare, education, law enforcement, and youth development. During the 2019-2020 prevention grant period, there were a total of 23 evidence-based suicide prevention strategies being implemented across the state, and an average of 5 being implemented per county. A few examples of these efforts in suicide prevention include in Fremont County, the county participated in Northern Arapaho Suicide Prevention Strategic Planning with the Substance Abuse and Mental Health Association. Natrona County is working with local retailers to provide free gun locks to anyone who needs and wants them. They also plan to attach a luggage tag on each lock with information for the suicide hotline and other resources. Sweetwater County partnered with the Rock Springs School District to educate parents on suicide prevention. Teton County is working with St. John's Health and the Jackson Hole Community Counseling Center to put on a 3-day mental health symposium. Campbell County hosted a Question, Persuade, Refer, or QPR training that had 75 attendees from Powder River Energy. Campbell County also hosted a QPR training for city employees who have not taken it or need it to complete an annual requirement. Carbon County hosted Assist and QPR for the hospital staff as part of their plan to implement zero suicide. Johnson County also completed Assist training in both Buffalo and Casper. And Lincoln and Sweetwater counties came together to train a total of 60 people in mental health first aid. As you can tell from these activities, suicide prevention requires and promotes participation and ongoing education from members all across the community. And I think of the programs that are there, nothing exemplifies this better than the evidence-based strategy that's being implemented in 14 counties called Assist, which is Applied Suicide Intervention Skills Training. It's a 2-day, 2-trainer workshop designed for members of all caregiving groups. With the mental health impacts COVID-19 is also starting to have on communities in our state, we find the work of suicide prevention to be urgent, and we appreciate your attention on it this morning. I'd be happy to stand for questions.
Okay, questions from the committee? Senator Schuler.
Thank you, Madam Chair. I attended a meeting of the Wyoming Prevention Alliance here just recently. It was mostly the Western region folks. It's amazing all that they're doing in our communities. It's really working, and I think they're making a difference. But one question I had, and I forgot to ask them, because I think it's important with our funding issues, is it all federal funds that deal with this grant, or is there any type of match with the state? Could you give me a little more information on that?
I might get some help from, sorry, Madam Chairwoman, from Jeremiah, but I believe the funds that we have for the suicide prevention grants are general funds from the legislature. Our other coalition funding for substance abuse and tobacco prevention are the federal funds.
Madam Chairwoman, that is correct, that the suicide prevention grant itself is specifically general fund provided by your body.
Right. Representative Hallinan.
Thank you, Madam Chairman. I'd be interested in what the suicide rate is over the last several years since these program changes have been put into place. Thank you, Madam Chairman.
Commissioner Macker.
Madam Chairwoman, Representative Hallinan, I don't have what it is, of course, for 2020. The data that we have from the Department of Health has 2018 when the Wyoming suicide rate was 25.4 per 100,000, which is compared to the national rate of 14.8 per 100,000. I think the Department of Health may have additional data that looks at those trends over a longer period of time prior to 2018, but I don't have data that is more recent than that.
Ma'am,
Yes, Elizabeth.
we do have a representative from the Department of Health. We can let into the meeting at whenever you wish.
Yeah, go ahead and let whoever is there in, and I think that may be helpful during the discussion. Representative Stivar, I think I saw your hand, but it went away again. Were you trying to ask a question?
The question I have is over this COVID crisis, I know I've talked to a few volunteers for the crisis hotline, and they're saying they're getting overwhelmed. I know at least 4 suicides over this COVID. How are we dealing with that? Or how's that being dealt with?
Commissioner Macker.
Thank you, Chairwoman. Representative Stivar, it's my understanding that counties and coalitions have worked directly with the Department of Health as the pandemic set in to shift and adjust programming to meet needs that they are seeing specific to that. I think when we look at the prevention coalition structure and model, generally that we separate through these grants prevention work from treatment work, and that has been a pretty specific part of these contracts. But I do know in our county and in other members that participate in our Health, Safety, and Social Services Committee at the association that the Department of Health, through the work agreements that are in these contracts, allowed for shifting of programming to respond within the community. So I think hearing that about the hotline has been a question that we've been interested to see as that has evolved, is what are the numbers and are there increasing needs so that coalitions can respond to that.
More questions for the
Thank you.
commissioner? Senator Scott.
Madam Chairman, 2 questions. One very simple. The gentleman, Mr. Ryman, was it? Who is he? What's his position?
Very good, Chairman. We will make Jeremiah introduce himself. Formerly at the governor's office under Governor Mead's administration. Now he is the executive director of the County Commissioners Association, I believe. But Jeremiah, I'll let you flesh that out more correctly if I've misstated anything.
Yeah, Madam Chairwoman, you're right. Again, my name is Jeremiah Riemann, and I serve as the executive director of the Wyoming County Commissioners Association.
Okay. Thank you. That's a formality, Madam Chairman, but an important one.
Indeed.
My question is for both of these, particularly Natalia, as experts or lay experts, at least in the suicide prevention field, I'm quite concerned with the budget situation that the state is in, that because mental health generally, including the suicide prevention, including all the other mental health things, is neither education nor something with big federal matching funds, that it may wind up being a target for some of the budget cutting efforts. And what I want to do is understand in the suicide prevention area, we know a good deal about these hotlines and the other prevention activities that are funded through this budget footnote. But what is the role of particularly the community mental health centers as the state, the Title 25 process, as they treat severely mentally ill people, where suicide is a risk that the mental illness that they have creates. If we lose the community mental health centers, what's that going to do to our suicide rate?
Commissioner.
Thank you, Madam Chairwoman and Senator Scott. I think it's a great question. I share your concerns. And I may let folks from the Department of Health comment further. I think with prevention dollars everywhere, it is sometimes harder to balance the difference between money spent on prevention versus money spent on treatment, but that we should remember that money spent on prevention is hopefully avoiding some of the more intensive interventions that are needed later that are often more costly. It also sometimes makes it harder to track because you are measuring a negative because the occurrence didn't happen. and that we do want to see our suicide rate going down. And I guess the other comment I'll make is just an observation, having not been involved very much in the prior prevention program delivery, but been very involved in the shift to counties, is that with the coalition model, what we see in the dollars that are deployed there is a lot of leveraging of other community resources, because a coalition of community members are coming together and bringing their expertise from anything from youth sports to owning a business and dealing with employees. And so I think we are seeing the impact of those dollars magnify in the community through this coalition model, and something that over time, as those relationships become even stronger, will hopefully be impactful.
Madam Chairman,
Senator Scott.
Madam Chairman, I think that's a key point. As one of the things I think we hoped for when the change was made. The previous system wasn't necessarily bad, but it worked in some counties quite well. It worked in other counties not well at all. And I'm hoping we're getting a more uniform, effective, not necessarily uniform in programming, but uniform in actually getting something done across the whole state with the current setup. Is that what you're seeing, that this business of mobilizing local resources is occurring statewide in most of the counties, if not all of them?
Commissioner.
Madam Chairwoman, Senator Scott, yes, I think we have, not without its hiccups at the beginning, but now that coalitions are in place and we have what I believe to be our well-established and ongoing methods of communication with the Department of Health to be able to make adjustments as needed, we are seeing those dollars get put to work in communities with oversight from local coalitions that are able to respond and adapt to their coalition activities to an occurrence that happens in a community. So if there is an event in a community, that coalition is poised and ready to mobilize, to respond, to make prevention resources available, and to chart a path to the future to keep avoiding having those occurrences happen.
Representative Stivar.
Yes, could we get WAMSAC Andy Somerville on? She's got some comments she'd like to make.
LSO, yeah, Ms. Somerville did send me an email, although it's kind of hard to manage all my emails and this at the same time. But yeah, why don't we bring, she'll have some comments on the suicide lifeline, and I'll call upon her later as appropriate. But so I have a couple of questions. One is, and I appreciate the oral presentation is super. Is it possible to get for the committee to receive a list of all the counties and what they are doing? I admit I did hear earlier this year that, and I don't even remember who I was talking to, that they felt like some counties really weren't doing anything. And so it would be really helpful to get a typed up list if that is possible. And could you remind me, either Commissioner or Mr. Riemann, what was the methodology for allocating the money? Was it population based, or how? I don't recall, or based on some sort of a grant thing. Do you remember, Jeremiah?
Madam Chairwoman, I don't know off the top of my head how that is distributed, but we certainly have Stephanie Pyle with the Department of Health who could go into that, and perhaps Commissioner Macker has that. To your first request, we will work with the Department of Health to provide that information. One of the great things that has happened over the course of the past 18 months or so is that we have a monthly call with the Department of Health and in particular Ms. Pyle to go through what is happening in local communities. And that happens with our Health, Safety and Social Services Committee here at the association, which then allows us to show other counties the great efforts that are happening and distribute the wealth of knowledge. And in doing that, we're also working with the Department of Health to prepare what I call perhaps a dashboard that presents some of that information, not only about suicide prevention, but other substance abuse and mental health issues that are funded through these grants. So we can work with the Department of Health to get that information to you.
Great, and I'll call upon, I see Stephanie's on, so that's something. And the third thing there to follow up, and maybe Stephanie can give us on this, and we've asked about, Representative Hallinan asked about the suicide rates, and the commissioner's point about measuring a negative is certainly a valid one, but you know, a lot of the activities that you present or, you know, summarized, quite a number of them are very process oriented, which is in a way what prevention is. But I think it's important to try to, you know, look at suicide rates at various points in time so that we can see if gathering together 70 people in a room for a training is anything other than just a process. Or, I mean, you know, is it, we need to be able to measure the effectiveness of this. And I know from my experience, a lot of groups are very enthusiastic about their programming, but maybe not so great at gathering outcome data. And so I just kind of putting everyone on notice that I'm going to keep trying to chase some outcome and accountability data on this. Before I'm just going to switch to and ask Department of Health some of these questions. Is there anybody else have any sort of initial questions for Mr. Riemann or Commissioner Macker? Okay, Ms. Pyle, are you there? You're muted. I see your name and a lot of little tiny people in the conference room. Okay, there we go.
Good morning, Madam Chairwoman. This is Stephanie Pyle.
Hi, Stephanie.
Hello.
Thanks for being here.
Of
What can you
course.
tell us?
Well, good morning, everyone. Committee members, it's good to be here this morning to have a few minutes with the committee on this topic. As you will recall and what you've heard this morning, we have been involved in ongoing work to restructure how prevention services are delivered in Wyoming. We're currently closing out on a full biennium under this new model. And as you will recall, the system was restructured to get funds to communities more directly, not only in the area of suicide prevention, but also in the areas of tobacco prevention and substance abuse prevention as well. As a result of this restructuring, we have developed a very strong working relationship with the county commissioners. As you heard, we do have monthly meetings with members of the Health Committee to maintain a high-level overview of activities, issues, and successes. This has really given us the opportunity to work quickly to address any problems that we hear about. And probably even more importantly than that is the work that happens between our program staff and the local community prevention specialists. Our team is able to provide them ongoing support and technical assistance as needed. And in addition to that, there are ongoing calls that occur between all the counties and our team, allowing for networking, sharing of ideas, and problem solving. We hope that this has been a mechanism that has allowed for quick response to issues as they occur. We believe this transition has allowed for a more robust system, more consistency and uniformity, as was mentioned earlier. And, we've been able to build on the work that was being done prior to this change in the infrastructure. In some ways, the transition has been difficult, and it hasn't been without, issues that we've happily worked through to find solutions. And I believe that having more engagement across multiple areas, both from the legislative perspective, from county commissioners, and from local coalitions, as well as the state, is a really important factor in increasing awareness of the importance of prevention. While our system is not perfect, I believe it's stronger today than it has been, and we continue to strive to make a system that gets better with time. I want to touch on a couple of points that have been mentioned. The prevention system that we developed that took us into last biennium was provided through funding that is both state and federal. The state general funds are what's used for the suicide prevention activities. And we do have federal funds for tobacco prevention and substance abuse prevention. So as the committee will recall, we have $8 million to put towards these prevention efforts. 2 million of that is state general funds, and there's a small amount of tobacco settlement funds that make up that 2 million. So one of the strengths of this system, I believe, is that local coalitions can pivot quickly and make changes as necessary to respond to issues that they are facing, such as the impacts from COVID-19. That has been very important this year, of course. Currently, we are not seeing a change in numbers in terms of number of suicides per year. However, the impacts of COVID-19, as I'm sure everyone is aware, are going to be long lasting. So we need to be prepared for that. And that's an area where we would expect to see additional work between our staff and the local communities so that we can be prepared for that and have an ongoing alert in that regard so that we're ready to help people who may have a need. We also, I do want to take a moment to mention that the Suicide Prevention Lifeline, the Wyoming-based call center, did go live last week. We are very thankful that we were able to get that up and going quickly after the governor and the legislature approved that funding during the past session. The Lifeline operates from Wyoming 5 days a week, 8 hours a day during peak call times. The calls outside of those times are still answered by national call centers, but it's been very important to have that local resource in place so that as callers are reaching out, the staff that's running the call center through Central Wyoming Counseling can quickly connect them with local resources. They can do a warm handoff. They can contact local authorities if the situation warrants it. And we've already heard of the positive impact this is making on individual Wyoming residents. So we're pleased that that has been up and running. And many thanks to Representative Sweeney for attending the ribbon cutting of that last week. It was good to see you there. And of course, thanks to the governor and the legislature for providing the funding that allowed that call center to be up and running. I did hear a comment about the concern over the budget situation. And I can tell the committee that while the budget reduction information is not being released at this time, the funding for the Suicide Prevention Lifeline is not currently being considered as part of that reduction. We are happy to provide the follow-up information that you asked for in terms of activities that are happening at the community level, and any additional information that you would like. To answer the question about how the funding was determined, we determined a base amount for counties and then took into consideration the population of the county to make that determination. And just as a point of clarification, the committee may recall that Platte County did not opt into the prevention infrastructure system during the last biennium, but we're very hopeful that they can opt into that during this biennium. So we are working closely with them to hopefully help them transition into the system so they can receive the funding. And just one final area, keeping in mind that the suicide rate that we provided, or that Commissioner Macker provided this morning, was the 2018 rate. And so, of course, this system started in 2018, and we've just completed the full biennium under this. We're wrapping up the biennium now. And we also are looking at the effectiveness of prevention and outcome data, and we'll be happy to provide that information to the committee, as well as the list of what counties are doing and how things are going at the county and community level. So I appreciate the committee's ongoing interest and support in this topic and everything related to prevention, and would be happy to stand for any questions.
Questions for Ms. Pyle? Chairman Scott.
Yeah, thank you, Madam Chairman. The question I have, I'm trying to understand how suicide fits into everything else here. Of the suicides that we have seen, do we have any idea of what percent of those people have some kind of an underlying mental illness that has been under treatment or is under treatment or should be under treatment? Do we know anything about that? What's the interplay between the mental health treatment and the suicide rate?
Ms. Pyle?
Madam Chairwoman, Senator Scott, we would be happy to provide that information to you to the extent it's available. Some of those elements are not always known, but we can look into that more and provide what's available, both at the state level and nationally.
Yeah, and Madam Chairman, state level data is always useful and interesting, but on this one, probably we're trying to understand the basic epidemiology here, and frankly, national data would also be useful in giving us some guidance as to what's important and how these various pieces of our whole mental health system fit in together. Because I am concerned that if we aren't careful, we could get the whole system unbalanced with budget cuts and have consequences that we don't expect. So yes, I'd be very interested in having that information. And Madam Chairman, I'm probably going to have the same set of questions for almost anybody that's going to testify on this area.
Representative Sweeney, I think your hand was up.
Thank you, Madam Chairman. My question on CARES Act funds, are any of those available through the Department of Health? And maybe you already insinuated part of this, in particular, the new call center. Is there any money available that could be shifted to help? I don't want to use this word, but backfill in these cases to stretch the budget a little further, because Representative Stivar brought up a very good point about suicide rates and the impact of COVID-19, and it's directly related, I believe. So just was wondering about that.
Ms. Pyle?
Madam Chairwoman, Representative Sweeney, thank you for that question. That is a very good question, and frankly, one that we've been wrestling with since the state received the CARES Act funding. I think we need to be very cautious in that regard because of the limitations that are put on that funding. So that anything that was a budget item prior to March essentially may not be eligible for that CARES Act funding. But we are looking at that really on a week-to-week basis. Is there anything, in our area that we can use the CARES Act funding for where it would be appropriate? So we are certainly doing all that we can to maximize the CARES Act funding that we have in relation to, making our current efforts more robust.
Follow up, Madam Chairman.
Representative Sweeney?
Thank you, Madam Chairman. And that leads me to this question is, you may not be able to tell us, but on the Prevention Coalition and these dollars that basically have replaced the PMO, are we part of the budget cuts that the governor has proposed? Has it been across the board, or these are dollars well spent? And my belief is we should get more aggressive with the CARES Act funds in places like this. And they can easily be spent by the end of the year, but that's just, are we part of the budget cuts, or can you not talk about that?
Ms. Pyle?
Madam Chairwoman, Representative Sweeney, of course, as has been the message this week, I don't want to get ahead of any formal announcements, but the $2 million that are allocated to us for the counties are not part of the current budget reductions, the 10% reductions that we're looking at. And I completely agree with your sentiment about maximizing the CARES Act funding in any way that we can, and we'll continue to do that as appropriate. So thank you for that.
Thank you.
Representative Hallinan.
Thank you, Madam Chairman. I wonder if Ms. Pyle can guarantee that the entire committee will get that data about the rates, suicide rates, and also the questions that Senator Scott had. I'd like to know what the epidemiology of these suicide cases is as well. So I think the entire committee would benefit from having that information made available. Thank you.
Thank you. So, Ms. Pyle, I think I think I'm speaking for the committee here, and I'm certainly speaking for me. What I think would be really helpful for us in just following up on the change from the footnote and also understanding in general, if we could get a list by county of the grant recipients, the dollar amount, and what it is that recipient does, and if it's also possible to have, I'm visualizing this in a sort of a chart, if it would be possible to get the number of suicides or suicide rate for that county, say 2016, 17, 18, and 19. I appreciate that would only be one calendar year since the switch, and I think we're all aware that you can't draw conclusions based on 1 year, and there are a lot of other things. But I think in addition to just getting a grasp of what the counties are doing, and it would also alert us to the counties where, in an epidemiological sense, it is a bigger issue than elsewhere, because it's possible, certainly possible, that the incidence of this is not evenly distributed across counties or across population. Would we be able to get a chart of that sort?
Madam Chairwoman, yes, we can provide that. I'm happy to have my team work on that. I would also like to mention that Wyoming has recently become part of the Wyoming Violent Death Reporting System. That's a national database that helps us look at violent deaths and understand more about causation and other impacts. So I am happy to provide that information to the committee to help with the committee's understanding of the complexity of these issues and to just continue our work together on the prevention system in its entirety. So thank you for that request.
Well, and so with this database, do you think it would be helpful for us to also see what the homicide rate, say, was in that counties? I mean, it may be that there's a sort of a cultural linkage or something between those two types of behavior, or is that what you're thinking?
Really that system, I'm sorry, Madam Chairwoman, that system does allow us to look more deeply into what's happening. And so some of the other factors that may have been evident, to the extent it's known. Of course, we don't know all of those things and all the information isn't in there. But I think it would certainly be worthwhile to have our team take a look at that and to provide the homicide data as well. So we're happy to do that.
Senator Scott. Are you raising your hand? Senator
There we
Scott.
go.
Yeah.
Madam Chairman, I would caution on that request. We're talking about, fortunately, small enough numbers and the size of our counties and our population. I would strongly caution about putting too much emphasis on county by county rates here, because the numbers are so small that statistically they're going to be all over the place without much really ability to infer causation, because you just have a certain random factor in some of these things. This is one case where I think the statewide rate is much more informative, because the numbers we're dealing with are larger. Even on a statewide basis, you do have considerable possibility of some random fluctuation. So just a caution, and if it's readily available, that's fine, but I wouldn't want to touch off a big effort because I'm concerned that statistically the information may not be worth very much.
Well, and I understand the concern over, reading anything into small numbers because, if you've got a very small population and one year you have one suicide and the next year you have two, you can't read much into that. But I think over time, and I would assume that the numbers are coming from the county coroners anyway. So I wouldn't think that it would take, I think over time, not this year, but if we start collecting now, that over say 5 years, if we see that certain types of prevention interventions seem to be associated with drops in suicide and other types are not, I think that suggests, as a psych major in college, we always said more research needs to be done. But I would think that sort of information, anecdotal as it might be over the course of 5 years or so, might suggest to people that it would be worth looking a little more into associations. Keeping in mind, of course, that they may not be causative, but you certainly can't rule things out unless you collect the data. I think I saw another hand someplace. Senator Baldwin.
Thank you, Madam Chairman. I think that in my mind, I'm more interested in, rather than a county by county, I'm interested in a demographics. And I think that will be separated out, age, race, et cetera. And I think that'll separate Safe Outback County. But I think the more important is the demographics compared to nationally. What do the Wyoming demographics compare to the rest of the nation, and I think that's the most important feature here rather than county to county.
Well, and that's a separate thing because that the demographics is valuable for understanding what's going on with suicide. But the thing that prompted me to put this item on here is the fact that we decided to switch our funding and run it through county commissioners. And frankly, I want to know how effective that method is, and if some county commissioners are more effective at coalescing prevention activities than others. I guess that's the 2 years on JAC in me. But we want to know it all, Ms. Pyle. We want to know all of that. So just busy yourself about gathering all that stuff. Okay, let's see. I think we also have Andrea Somerville is in the room, and I think we may as well take the opportunity. It's not exactly part of the county commissioners, but we may as well hear from her now on the hotline. And if you want to throw anything into this mix, I guess that would be a good time. Ms. Somerville.
Thank you, Madam Chairwoman. Again, my name is Andy Somerville, and I'm the Executive Director for WAMSAC, your Community Mental Health Centers. And so I just wanted to share a few things that are relevant to this conversation. Ms. Pyle touched on the opening of the Suicide Lifeline. It's been open for about 10 days. They are averaging 5 to 10 calls per night, with at least one of those being a serious incident. And so I think right out of the gate, it's demonstrating the need for Wyoming. One of the things that we're looking at is right now the funding provides for 8-hour shifts, 5 days per week during peak call times. And I think going forward, one of the questions is how do we expand that as we look at the number of calls that are getting routed out of the state after hours when they are not open. We can speak directly to the importance of doing that warm handoff, and that is happening with these serious calls that need immediate intervention, either to law enforcement or to mental health counselors in those states. Our local Suicide Lifeline Center, run out of CWCC, has the ability to make those direct connections, stay on the phone with somebody until that help arrives. And I think we're starting to see just immediately in those first 10 days, some very positive results. So that is something that we're looking at going forward. And then I wanted to touch on just real briefly how the community mental health centers are kind of working with this new funding model that's going through the counties. So quite a few of your community mental health centers are participating directly with providing prevention services. and they are involved in providing mental health first aid training. They are involved in suicide crisis response. So if there's an issue in that community, the community mental health centers are part of mobilizing that team and getting a response out to the community to deal with that. All of your community mental health centers provide crisis intervention as a core piece of their work, and that dovetails both with the suicide prevention and the response to any incidents in the community. A couple of the things that I just wanted to mention in response to some of the questions that have come up. We know that the prevention model works when it's done well in a community coalition. We know things like mental health first aid training show results, depression screenings for elderly show results, cognitive behavioral family treatment for teens that are at risk for suicide. The studies show that those items work. And then specific to Senator Scott's question about some data, I'll just share a few things here from the national level. About the percentages vary wildly, but about 30 to 70% of suicide victims have either a major depressive disorder or bipolar disorder. So there's a strong link with underlying mental health disease. We know that it is about 6 times higher, the suicide rate in those that are suffering from substance abuse issues as well, and that can affect women even more significantly, with a 6 to 9 times higher potential for suicide if they are struggling with a substance abuse addiction issue as well. So I'm happy to provide more specific information to the committee broadly to dovetail with Ms. Pyle's presentation to the committee if you guys want additional data from your community mental health centers. But with that, I stand for any questions from the committee.
Questions for Ms. Somerville? Senator Scott.
Yes, Madam Chairman, just a clarification. The percentage you said had underlying either depression, or what was the other category you gave, and what was the percentage you gave? I got confused as to which percentage applied to what.
Ms. Somerville.
Thank you, Madam Chair. Senator Scott, it's major depressive disorder or bipolar disorder. And those are a combined category, and it ranges across the nation from about 30% of suicide victims have those to 70%, depending on area and geography.
Thank you.
More questions for Ms. Somerville? Oh, Senator Scott.
Madam Chairman, thinking about the role of the community mental health centers in the suicide area, are they one of the resources that gets called on? How do they relate to what comes in over the suicide hotlines?
Ms. Somerville.
Madam Chairman, Senator Scott, so they are very, very involved in how that, in responding to any suicide attempts or suicide incidents within the community. First and foremost, as you guys just heard, CWCC is running the suicide hotline. We felt it was important to bring one in the state because it allows that hotline to directly hand those off to the community behavioral health providers in that person's community and make that warm handoff. So if a call comes in on the National Suicide Lifeline, goes into our Wyoming call center, that caller gets direct resources handed off to them. They're not leaving the phone without having somebody else on the phone if that's what's needed for that call. They're also very often the providers. So if somebody has a law enforcement contact because they've attempted suicide, the community mental health centers are generally the ones sending in somebody to assess that person and set up treatment and planning. And then, of course, we're involved in a number of ways with prevention activities that go on county by county. And that varies a little bit county by county, as you guys have moved that model to letting the counties kind of individually make that decision. There's different involvement at different levels, but we're there from prevention to the emergency call through the treatment.
More questions for Ms. Somerville? Okay, thank you.
Thank you, Madam Chairwoman.
Elizabeth, do we have anybody else that we haven't brought in yet that was going to, I mean, there's obviously a lot of other topics, but anybody else specifically on the suicide prevention side?
Yes, ma'am. We have Brittany in the lobby. I'll admit her at this time.
Okay, thank you. Brittany, are you there? Aha, here you are. Great. If you'll introduce yourself.
Yes, good morning. My name is Brittany Wardle. I am one of the local community prevention specialists working at the project director level at Cheyenne Regional Medical Center. And thank you for the opportunity to be here, Madam Chair and committee members. I absolutely concur with the remarks so far from Commissioner Macker as well as WAMSAC. Suicide prevention is a very important issue, and I just want to highlight some of the outcomes related to our work in Laramie County for suicide prevention. So as some of the discussion has indicated, it's important to remember that there are process-oriented tasks, and some are more aimed at addressing infrastructure. So for today's purposes, I've tried to focus on those that are really addressing the way we do business and how we might improve that as it relates to suicide prevention. So in Laramie County, our coalition is called the Behavioral Health Action Team. When we started just over a year and a half ago, there were 3 separate groups in Laramie County meeting on suicide prevention. And so through the funds that we were given from the Department of Health and our Laramie County commissioners, we were able to join those groups into one cohesive group. That does include some of the stakeholders you guys have discussed, our Laramie County coroner, so we can really get into the details about what we're looking at in Laramie County, our community mental health centers, nonprofits, and other partners that are invested in this work. So we're able to avoid duplicating services across the continuum from prevention all the way through treatment, as we have all of those partners together at the same table. We were able to complete a Laramie County behavioral health resource assessment so we could gain some understanding as to what does the environment look like in Laramie County, what do we have, and where are those gaps that we can address, whether that's through prevention or through treatment. We did that through patient focus groups with our primary care providers about how it looks for them to refer into the behavioral health system, and then also those agencies that are providing behavioral health services in Laramie County. It brought us several priorities that we're going to be looking at addressing over the next couple of years. One being, particularly for our patients, reducing that duplicative paperwork that we ask them to complete everywhere that they seek services. So how can we reduce that burden for them? In addition, one of the priorities that came up is really how can we improve behavioral health care for our youth and young adults? We know across Wyoming that that is an area where we lack a lot of access for our youth and young adults, and they're oftentimes sent out of town, away from their communities, away from their support systems to access that care. The next point I want to make is related to our crisis intervention training directed patrols. This is a partnership with our law enforcement and our community mental health center. So that includes both the Cheyenne Police Department and also the Laramie County Sheriff's Office. Through those patrols, we have officers that are trained in crisis intervention for substance use and mental illness, who respond to incidents involving subjects who may be under the influence of alcohol, opioids, or other drugs, as well as subjects who may be suffering from acute mental distress. So the purpose of those patrols is to be proactive in responding to those citizens or doing proactive community outreach and diverting those individuals away from the criminal justice system and helping support them if they are indeed ready and appropriate for treatment, directing them to those resources, and if they have other identified needs in the community, working with our partners to make sure that they are directed to the place that's most appropriate for them. Because we know that incarcerating those individuals for mental health or substance use issues is a burden for our county jail and their budget. And it's also not helpful to that individual that really needs services rather than incarceration. And I did share documents with the committee that demonstrate the results of that strategy, of how that patrol impacted our community in the 18 months that it was operational. And so I'll just cover those very quickly. Our officers and deputies conducted 824 hours of diversion patrol. Through those hours, we had 125 individuals that were diverted. So the primary diversion was for suicide. Many of our calls for law enforcement service are related to mental health or suicide. So that was 54 individuals diverted for suicide. We had 31 for alcohol, 1 for opioids, and then 71 that were classified as other. Those individuals that had interactions with law enforcement were diverted to, 65 were diverted to counseling, 16 to group support, and you can see the largest number here, 72, were diverted to housing. So this is a strategy that our community has used to ensure that we're able to address some of those holistic factors that really impact suicide. And finally, I'll mention the Zero Suicide Initiative, which I know was mentioned by Commissioner Macker. That is a community partnership for system-wide transformation towards safer suicide care. What that means is we have several partners in our community here in Laramie County, Cheyenne Regional Medical Center, Peak Wellness Center, and Grace for Two Brothers that work together, not only in their organization, but as a collaborative to ensure that we can change policies and put practices into place that improve the way we provide care. An example of that is we know that some of the times of highest risk for individuals is after they're discharged from the emergency department for a suicide-related visit, as well as after a discharge from an inpatient behavioral health visit. We know from the literature that those are times where people are at severely increased risk for dying by suicide. And so through the Zero Suicide Initiative, we've been able to put training in place for all employees at those organizations, whether they work in environmental services, whether they provide direct patient care, but making sure everyone at the organization has some form of suicide prevention training. We were able to complete an entire workforce assessment at Cheyenne Regional, which is just over 2,000 employees with an 80% response rate to see what are the needs within our health system. How can we better provide care within the facility and also as patients transition into the community to our other partners. And additionally, as a group, we've been able to offer some of those trainings that we've heard this morning, QPR and ASSIST, within the community, but also to assist with internal policy work, identifying what are the most effective screening tools for capturing those who are at highest risk when they're coming into our facilities, and then also making sure that we are, again, improving those care transitions in the community for those that are coming in and out of the emergency department, inpatient behavioral health, or an outpatient setting. So with that, I want to highlight that these funds have allowed our community to work comprehensively in our efforts around suicide prevention, and I am happy to stand for any questions.
Very good. Questions for Ms. Wardle? I do have one. I was curious, the high number of people who were diverted to housing. Could you just flesh that out a little bit? Are we talking like temporary at the Comea shelter, or what role did the housing play in whatever the situation was, broadly speaking?
Madam Chair, thank you for that question. Housing is an issue that we've seen come up frequently in Laramie County, and I think a lot of that depends on the individual. So oftentimes officers that are out in the community will have a list of resources, a very comprehensive list, and depending on that individual and what their needs might be, and then again what their background might be. If I'm a veteran and I'm interacting, I might have different options for housing than if I'm not. So they refer, of course, many times to Comea because that is one of our only options for temporary shelter, but Also, they are aware of resources depending on what that individual has in their background that give them access to additional resources.
Do you think that, and I realize that you might not have an answer to this, do you think the housing problem is causative of, you know, I mean, and of course I don't know which ones were linked with suicidal or other that might be alcohol abuse, or the housing problem is often a result of a person's behavioral health issues. Do you have any input? Just, I mean, we can't solve that right now, but do you have anything to say to flesh that out a little more there too?
Madam Chair, thank you for that question. I think housing is a very complex issue. And I think that it's safe to say we have individuals who have experienced homelessness because of their addiction and mental health. And I think we can also say the reverse is true. So I think when you look at suicide, it's a very complex interweb of issues. We know that risk can build upon other risk. And so if you have unstable housing, that adds to your risk. If you have a substance use addiction, that adds to your risk. And so I think the important thing to know is often people might not be in a place where they can access treatment until we fix the stable housing problem. And so for us in Laramie County, I think the struggle has been, how do we get people housed and have policies that support their ability to be housed stably and then seek treatment? Oftentimes that's referred to as a housing first policy, where CAMEA here in Laramie County requires a breathalyzer to enter their facility for many reasons, which include the safety of their residents and other things like that. But I think it is important for us to acknowledge that oftentimes these things are very intertwined, and to pull one out for the other, we really need to operate on, you know, like Maslow's hierarchy. Let's work on stably housing someone and then see what else we can help them with.
Okay, more questions for Ms. Wardle. Representative Barlow.
Thank you, Madam Chairman. So several years ago, when we were having the discussion of changing the model, part of at least my interest was ensuring that we were having fully leveraging the private nonprofit world. And certainly in Cheyenne, there's an organization that's I think quite active. Casper has one, Campbell County has one. They're around the state. So I guess I'd like an impression, at least from the Cheyenne Regional Medical Center perspective, if they believe that in their community, the private nonprofit world is being brought into the coalition, is being appropriately, or is part of the coalition and engaged in that. And then I just so that'd be my question. My second just comment to the chairman is, I think housing, transportation, et cetera, all social determinants of health. Probably if we wanted to get to costs of healthcare, et cetera, if you participate in the most recent CSG West, there were some pretty good examples from neighboring states of what communities and larger systems are doing about social determinants of health, including housing and other resources. So that might be a topic for, obviously a topic for another meeting or another focus, but I would appreciate the first question on private nonprofit engagement. Thank you, Madam Chairman.
Ms. Wardle.
Madam Chair, Representative Barlow, thank you for that question. I think especially in Laramie County, we are fortunate here to have a great number of partners that are invested in this work. I think especially from the perspective of Cheyenne Regional Medical Center and our behavioral health action team, we do want to capitalize on those private and nonprofit partners in our work. And we have. I think what will further drive collaboration in those efforts is as we see layoffs and as we see changes in the employment structure and how people are seeking assistance, that we can further involve some of our private partners. We've oftentimes reached out to some of our, especially our industrial partners in Cheyenne, and said, these are resources we can offer. We've talked with HR at Dyno Nobel, as well as the Holly Frontier Refinery, and said, these are what we can offer you and those you're working with. And oftentimes they'll bring us back different concerns, right? One of them stated, we're very concerned about proper diet and diabetes for our workers. They're sitting all day. How can you help us with that? So I think oftentimes our community does want involvement there and they do want to work with us. And it's really, as you mentioned, addressing some of those social determinants to get at our larger prevention objectives. And so I would say, yes, those partnerships have been very essential for us. Our commissioners have been great about pointing out those partners to us that they think we should involve further. And I do think for us in Laramie County, this change, although I didn't work in the previous system, so I can't necessarily speak to that. But I think for us, what's happening now is working very well.
Very good. Any more questions for Ms. Wardle? Okay, I actually have a question back for either Stephanie or Commissioner Macker, just to follow up and not point fingers or anything, but did Platte County have services before under the previous model? And do you have any, I appreciate you're not Platte County, but what is the reasoning that Platte County is not participating in this?
Madam Chairwoman, this is Stephanie again. So Platte County did take part in the system prior to the change. And, you know, of course, not to speak for Platte County, but what we know about some of the issues had to do with personnel, you know, just turnover, who in the county would take this on. And I think also a question about the continued availability of funding. And so, you know, as I said, we do stay in constant contact with Platte County through our public health nursing office there. And we're hopeful that they can enter into the system during this biennium so we can get those prevention dollars to Platte County.
Any comments, Commissioner Macker?
Thank you, Madam Chairwoman. I think the only thing I would add to that is that the concern around system change and ongoing funding was definitely something I think all the counties were cautious about at the beginning of this. And I think commend many of the counties for taking the leap a little bit and being willing to go in and set up some infrastructure and set up a system that over time has proven to be, I think, generally successful. A little bit to your point, Representative Barlow, about bringing back in some of the nonprofits that maybe hadn't been as involved in the system previously, and really regenerating that broader base of community support. So we definitely, when counties have issues, bring them into our monthly calls with the health department. And I think it's our hope on our committee at the association that we would get all the counties participating. Another piece that we are continuing to look for opportunities and is happening somewhat in some areas is focusing on county specific needs, but also what's the best way for counties to collaborate across county lines and have some of that regional approach when it's appropriate, particularly for some of the lower population areas.
Okay, any final discussions on this? Very good. I think this has been a really good presentation. I'm glad that we've been able to follow up on the shift. I think it's really the first time legislatively that we did, and I think it was it's time that we did, and I hope that we will continue following up on this, you know, especially with the budget changes with the state. We're going to need a lot more partners in a lot of activities. So Commissioner Macker, certainly from the, you know, or Jeremiah, folks involved in this, if there are issues that you think need legislative attention, we hope you will consider us a home committee for you and reach out and you know, participate and keep us informed. And Stephanie, we look forward to getting some more information so we can just continue understanding the situation as best as we can. Okay, very good. Next up, we have a lengthy report, or I'm not sure how lengthy the oral report will be, but I asked LSO to, oh wait, I'm sorry, I skipped ahead. Report on the Joint Subcommittee on Mental Health and Substance Abuse. And I asked, did Representative Larson give up? Oh, there he is. I asked Representative Larson is chairing the House side and used to be on Labor Committee years ago when we were all young and green. And so I've asked Representative Larson, even though Representative Barlow and I are also on it, I figured we'll let Representative Larson let us know what's happening there. It's a joint subcommittee between, with actually, what do we have, Representative? I guess it's 2 House Labor members, 2 Senate Labor members, 2 House and Senate Appropriations folks. So go ahead, carry on, Representative Larson. Just an update.
Thank you, Madam Chairman. I just wonder, before I start, I noticed as you was concluding with your previous subject that Representative Barlow had a class question that you, and you may not have seen his hand. Would you like to?
I beg your pardon, Representative Barlow. Did I miss a question of yours?
Madam Chairman, I was just going to ask Commissioner a question, but that's okay. It's all good. Thank you.
Okay, sorry about that. Thank you, Representative Larson.
Thank you, Madam Chairman. Mr. Chairman, Chairman Scott, it's good to see you and members of the committee. It has been fun listening this morning to topics that required a lot of time for me to get my head around. And as I said on that committee, I guess, Madam Chairman, I might just preface that I think all of us are aware that the mental health discussion is not new by any means, in that your committee, even prior to you and Representative Barlow chairing that committee, were discussing the role of mental health in Wyoming and how we fund it. We see a unique jurisdiction or with this committee and with the Judicial Committee, because mental health is often interacts with judiciary if there's a commitment to the state hospital or even to a correctional facility. And so getting those all of those efforts to conform is not an easy task. There were 3 committees that looked at some aspect of mental health: your committee, the Judiciary Committee, and the committee that I currently sit on, Appropriations. The Appropriations Committee and the Labor Committee had similar goals in working and trying to look at the providing of services to for mental health in our and how that relates to the state. Management Council, as you indicate, decided that it would be appropriate to have a subcommittee from the Appropriations and the Labor Committee, which you've indicated. We have Senator Schuler and Senator Bouchard from your committee, as well as you and Representative Barlow. We've met twice. I think and I know that your day is busy, so I'll kind of keep this in a nutshell. Kind of the direction that we've taken with this is, with all of the efforts that this committee has taken in the past, we've really tried to not try to eat the whole elephant at one time in the subcommittee, and are really kind of focusing on initially the community mental health providers and the services that they provide and who they provide services to. We finished that up. We really want to also look yet this year at the services provided to adolescents for adolescent psychiatric care. As this committee knows, there's a real challenge to provide services in this state to those, to our adolescent population, particularly if they have acute or severe mental illness. We oftentimes don't have the facilities, and see sometimes where we even see some of these kids in county correctional or county jails, and we shouldn't and can't do that. So really, committee, what we are trying to focus on right now in this subcommittee is to determine in a nutshell, what is the state's, what are our policies for providing mental health, or in other words, what is the role of state government in providing mental health to the citizens of the state of Wyoming, and how does that look? And what we've are trying to flesh out here is that if you take away the discussion on funding and you take away the discussion on constitutional or other statutory requirements, if we were to just have a discussion and say, okay, in this perfect world, what would the state's role, what is the role of government in providing mental health? And once you determine that, then what are the priorities in those services? And then how do we accomplish that? And then once we establish those policies, then we need to bring back in those other things that define it, such as the Constitution, such as if we have funding or not. And then we say, these are our policies. How is that impacted by the Constitution, or how is that impacted by our current revenue streams? And how can we mitigate those impacts? We spent our first meeting really more for the benefit of the Appropriations Committee, bringing them up to speed on the role and the structure of community mental health providers in the contracts between them and the Department of Health. The next meeting, we got a little further into the woods and started talking about priority populations, who that should be. I am left with the impression from those discussions that this subcommittee feels that really priority populations fall into categories such as indigencies, those impacted by judiciary decree, meaning people who are maybe coming out of the correction system back into communities and need help with mental health and substance abuse, those who may be in the legal loop right now for Title VII or Title 25 and are at risk of going to the state hospital or like institution. How can those be diverted? And then what kind of effort do we put on keeping them out of those facilities when they return, or a recidivism issue, and how can we do that? And then probably the last one that we talked about is the impact of judicial decree on families. If you go to a Child Protective Service issue where the court is telling a family that they're at risk of having that family split up and the children removed unless they get the appropriate counseling. We feel that that's also a priority population to do whatever we can to have families stay together and have children be in a healthy environment within their home. Madam Chairman, I participated in a meeting last week with the Department of Health and representatives from WAMSAC under the direction of Ms. Somerville, where we went through an exercise that this subcommittee will be going through on their next meeting on really, again, refining who these populations are and saying what the role of government is. I think the conclusion, and I won't share all the results because I don't want the committee members of the subcommittee here getting tainted by the results of what the WAMSAC group came up with, but there really seems to be a focusing of who those populations are and how we do that. But at the end of the day, I think that everybody agrees that it's not the role of government to form within the existing agencies a state-run organization such as a state hospital or likewise to provide these services, that our existing system using contracts with community mental health providers is the appropriate way to move forward, but to give them more direction on what or definition on what the state is expecting of them in their overall performance of providing mental health is a crucial part. or is crucial as we try to move forward. The intent, Madam Chairman and Mr. Chairman, is that the subcommittee will have some recommendations for some regarding policies on and how that would be impacted on current statutes back to this committee so that we can possibly have a build for our initial effort and have that come through as a Labor and Health Committee bill if this committee finds it worthy of such support. And then much like we did, as this committee will recall, back when we done the Medicaid reform, when we done the state health facilities, we established policy in one legislative session, and then during the following interim or two, refined how those policies would be interpreted by rule or implemented, and made additional statutory changes as that was refined with the help of the stakeholder groups and those involved. So we're hoping to have some recommendations for this committee to where we can lay the foundation for that work, particularly with community mental health providers and hopefully with adolescent psychiatric health, mental health moving forward yet this fall before your last meeting.
Very good. Questions for Representative Larson? I see none. Oh, Representative Barlow.
Thank you, Madam Chairman. So my question is, yesterday on Judiciary Committee, they had a proposal on Title 25, of course, which is at the other end of the spectrum from where we started this morning at prevention, and where we're talking about maybe more system-wide right now. Does anybody have an update on what actions that committee took? I didn't reach out this morning early enough to get to the chairman before they started their meeting. So if maybe Representative Larson or staff would know what action they took on Title 25, that would also be informative to our discussions. Thank you.
Thank you, Representative Larson.
Thank you, Madam Chairman. Representative Barlow, I was invited also to have a similar discussion as I'm currently having with you guys with Judiciary yesterday. They had two draft bills created by the County Attorneys Association on Title 25 as they reviewed that. And I guess their final action was to move forward and continue working and refining that for draft legislation. I think I will just give you an opinion. My takeaway on that is I think that they've had a lot of work going into that, and it appeared to me to be moving along in an appropriate direction. One of the things that they had recommended was reducing the hours before court hearing from 72 to 48. That got some pushback, as you would well imagine, from Ms. Somerville and WAMSAC and a few others. And so I think all of that was a healthy discussion. I think what's important in their effort and in our subcommittee's effort and in the Labor and Health Committee's effort is that we do, as you've suggested, be vigilant in seeing what each other's doing or keeping each other informed, because they're creating some definitions for mental illness and severe mental illness for law, in giving direction to law enforcement when they bring somebody in to potentially be committed, that they have to be severely mentally ill. Well, is that definition one created by the county attorneys, or does it have some clinical definition to it? I think we need to be careful of that and make sure that we're on the same page. I think as they too, there's some evidently some concern on the term gatekeeper. To me, I don't care if we call it Uncle Fred's Pancake House. It's what they do is what's important, but they are looking at changing the term of that, but their concern on getting continuity across the state from county to county is similar to what our subcommittee is also identified. And I think to make sure that we're working together to where we don't come with bills that have conflicting efforts on that will be important.
Representative Larson, in my brief review of what was posted on their agenda, I did see that it looked like there was going to be a proposal to take all the financial burden off of the counties and have it all go on the state for the first 72 hours or whatever time period they come up with. Did their bills going forward retain that shift of financial burden?
Well, Madam Chairman, thank you. And again, this is an opinion of a spectator and not completely sure what the chairman of that committee elected to do as I jumped ship when I was complete. But there was certainly discussion on the rationale behind that that thought of removing that burden from the county and putting it all on the Department of Health. Also, similar to that is in that proposal was to have the Department of Health form a committee, much like the ECC committee for the developmentally disabled. If we're looking for them to be approved onto a waiver outside the normal process, they want something similar for allowing for authorizing psychiatric prescriptions when the patient is refusing them, and taking that burden away from the judicial side. There was some pretty good discussion on that and some pushback on that. So I think all of those, what I would call significant changes in existing statutory requirements are moving forward with the intent that that needs to be refined. Department of Health wasn't there yesterday because of other commitments. And so they really, in Ms. Somerville, if she comes back on public comment, might give her thoughts on that as well. But my impression was they thought that there had been significant appropriate work on that whole effort, and certainly worthy of moving forward, but was not yet at the level of having a sponsored draft bill.
Okay, good update. Well, we can certainly visualize that any bill that plans to increase the cost to the state will be re-referred to the Appropriations Committee on the floor.
Whoa.
Thank you. Any further questions for Representative Larson? Okay, super. Thank you very much. Thank you so much.
May I be excused then, Madam Chair?
You may be excused, unless do you want to sit through and hear Senator Schuler and Representative Clem present review of adolescent site services?
I wouldn't miss it.
Well, if we can, let's move that up now so that Representative Larson can hear that, and we'll move LSO after Senator Schuler and Representative Clem, and I think they've got DFS or something going. But if we can hear that now, just so that we can, seeing as Representative Larson mentioned the adolescent issue, as far as the joint subcommittee, it'd probably be beneficial to have all the people hearing everything. So Senator Schuler, Representative Clem, take it away.
Thank you, Madam Chairman. I don't know, Representative Clem, do you want to go first, or what's your pleasure?
Sure, that would be great. Madam Chairman, yeah, I'll kick it off here. I know Senator Schuler had some more in-depth discussion with DFS, and so I would welcome any feedback from DFS or Department of Health. And basically what I'm going to present, mine, and I'm going to go ahead and share the screen here as well. I sent something to you in regards to this as well, so it should be in your inbox for Labor Health. But what you're going to see here is just a little chart that I put together based on my own past experience working at a residential group home here in Gillette. And what you see here, I'm basing this by and large off of the Wyoming Youth Service Association, which is a coalition of crisis shelters, group homes, and residential treatment facilities around the state. They're the ones who are mostly utilized by the state. by and large. I think it's probably a vast majority, if not all of it. However, there are private group homes. There are other private facilities around the state. However, they're not typically utilized by the state. So what you're seeing in front of you, just a couple of caveats, is this is in very general terms. As you look at this chart, of course, there's always going to be exceptions to the rule, and I'll explain some of these things as well. At the bottom, let me focus your attention right away to the questions here at the bottom. So that these are the things that I think it's important for you all as policymakers to really consider. And the questions are these considerations: what is good for the child and family? What is good for the state? What is good for the facility or program that's involved? And then problems that arise with moves in the continuum of care. So I'll briefly go through these real quickly. First of all, if you look here on your to the left of your screen, you'll see the blue boxes there. You'll also see the continuum of care. And so the green boxes list essentially this continuum of care, these programs that are designed for youth within, I guess, within this sector, if we want to call it that. And so you see the least restrictive are going to be community prevention programs. Those are going to be things like day treatment, perhaps outpatient therapy of some kind, high fidelity wraparound, which is utilized by the mental health waiver. We have mentorship, different programs such as that. And then you can see then below that, you'll have a crisis shelter placement. And so we're getting a little more restrictive there. That might also include foster homes as well. So if a child is removed from the home and they need to go to a foster home, or if there's no foster home available at the immediate moment, they would go to a crisis shelter to await further placement. Beyond that, we get more restrictive, and then we're getting to a group home placement. Moving down the ladder here, we're going to an RTC placement. The RTC stands for Residential Treatment Center. Sometimes it's also referred to as an RTF, or a residential treatment facility. It's the same thing. Moving on down, then we have something called a PRTF, which I know many of the committee members are familiar with. It stands for a Psychiatric Residential Treatment Facility. In addition to that, as far as the continuum of care, you might include inpatient hospitalization. Some ask, what is the difference between a residential treatment center, an RTC, and a PRTF, a psychiatric residential treatment facility? There is a big difference, and one is considered actually to be more of a mental hospital, and the other one is inpatient treatment for other mental health issues. And so the PRTF is really considered to be a mental health hospital. It could be for adults, or in this case, we're talking about adolescents or juveniles. And then as we move down to the very bottom here, the highest level of restriction, or the most restrictive placements that we have in our state, would either be the Wyoming Boys School and Wyoming Girls School, or juvenile detention. And so you can see this continuum of care moving from least restrictive to most restrictive. With that, you'll also see the other blue box here that has, it's less expense, or less money versus more. And so you can see, in addition to moving down the continuum of care of least restrictive to most restrictive, you'll also see that these are the things, it follows in a pretty consistent pattern, what costs the least amount of funds and what costs the most. And of course, depending on who the payer is, this could be a significant thing. And so you'll see here, really moving from community prevention, those are going to be your less expensive routes. Those are going to be things where you get the most bang for your buck, generally speaking. That's not always going to be the case. There are those exceptions. But these are going to be the things that are going to have your most bang for your buck. And then moving down, the most expensive really is going to be your psychiatric residential treatment facility, your PRTF. And so as Representative Larson talked about a moment ago, we have very limited amount of beds as far as PRTF beds within our state. And of course, those beds are going to cost less in general versus when we send kids out of state at a PRTF placement somewhere else. And that's going to cost the state the most amount of money. Now, a little caveat to that is this, typically these PRTF placements, if it involves a child in state custody, is going to be paid by Medicaid. And that's where you kind of see the payer over here. You can see what does the state pay as far as a placement in the bed. And again, I welcome if I'm mistaken on this. It's been a few years since I've worked in this field. If DFS may have to correct me, but I'm fairly certain that as far as paying for the bed, that's not something that the state actually pays for. Instead, it's paid by and large by Medicaid. Of course, Medicaid is 50-50. And also private insurance as well. Education, I can't recall if education pays for these placements as well. My recollection is at least at one time they did, if they were directed by an IEP or an individual education plan, as mentioned in the group home placement and RTC. But not to get too into the weeds here, just kind of wanted to show you the less expensive versus more expensive. The outlier here really is the boys school and girls school. I can't really tell you where that winds up in this continuum as far as the least restrictive to most restrictive. I can tell you this, that the Wyoming boys school and girls school is paid by the state. Those are things that are included in our budget. By and large, they have fixed costs. And so, for instance, let's just imagine, I'm not sure what the capacity of the boys' school is, but let's say that the capacity of the boys' school is 100 kids or 100 boys, adolescents. It doesn't matter if that is completely full at 100 or if it's, say, half the capacity, if there's only 50 kids there. By and large, your fixed costs are going to remain the same because these are state employees. It's state funded. It's within our budget. And so that's really kind of the outlier there. Moving on here, you see the payer. And what I tried to put here in the next couple of sections here is the payer and the placement. And there is a difference. In other words, who is the one who pays for instance, community prevention? And you have 4 different categories. You have the state, you have Medicaid, which also includes the state, you have education, and then you have private insurance. And so as you can see here, by and large, when it comes to community prevention, this is spread out amongst those 4 different payers. We do have funds that we give or that we pay as far as community prevention within our communities. Medicaid, as far as it depends on what the community prevention source is. For instance, outpatient treatment. Of course, Medicaid is going to pay for some kind of outpatient treatment or outpatient counseling that maybe a child may be getting. The same thing with private insurance. They're going to pay for some of those things as well. Then, of course, you have education. Depending on the community and the programs that are in place and what the school boards decide to do, you might have other different community prevention efforts in that arena as well. So it's not real cut and dry. You'd have to look at each of the individual programs to see who specifically pays for those things. But by and large, when we lump it all together, as far as community prevention, we see that the state, Medicaid, education, and private insurance all chip in there. Moving on down the road here, you can see there's some differences. And so for instance, the crisis shelter, we pay by and large for crisis shelter placements around the state. For those on appropriations, I know, Madam Chairman, you are on appropriations. We pay a per diem rate, and in fact, the way that we do this in Wyoming is we pay for a certain amount of beds, and we kind of divvy them up based upon location around the state. For instance, I believe in Campbell County, if it hasn't changed, I think the state pays for either 8 or 10 crisis shelter beds. And so that is a consistent number that the state pays for and utilizes those beds whenever they're needed. And so the state is the one who pays for that. There's other payers as well. It might be, for instance, parents, and you can kind of see that as far as placement is concerned. Of course, if a child is in state custody, they're court ordered, they're placed in the legal and physical custody of DFS for placement, let's say at the crisis shelter. And so the state can place those kids there, and they pay for that already. But you also have private placement options as well. And so, for instance, in Casper or in Gillette, you might have a family who's struggling with their child, and they need to take their kiddo to a crisis shelter, and they can do that. Now, Medicaid or education or private insurance is not going to pay for that. By and large, that's going to have to come out of their pocket. And usually they do this on a sliding fee scale. The only one who really pays the bulk of this really is the state, in addition to any kind of private funds or community funds that a community might put in as far as paying for a crisis shelter placement. For instance, in Campbell County, I know the city of Gillette and our county both pay the Yes House. They give towards that to keep that facility in operation. Similar with group homes and residential treatment facilities. The state pays a per diem basis, a fixed amount of dollars for basically they're paying for room and board to be at a group home or an RTC. Now, the difference there is, for instance, you might have a kiddo that's at a group home or residential treatment facility. The state is paying for room and board in that per diem amount, but they also might receive, for instance, in a group home, they might be going to outpatient therapy somewhere. Well, if they're getting outpatient therapy, then Medicaid is going to be paying that bill. Or if they're in an RTC where they're receiving inpatient treatment, they're receiving counseling and things like that. And so Medicaid or the private insurance is also going to pay for that. But as far as just the placement is concerned, the room and board, what you have is the state is really the one that's footing the bill. Medicaid doesn't pay for that. Education will pay for that if it is directed by an IEP. Private insurance will not pay for that. And that's the same for an RTC as well. If you move over to the placement, as far as who's allowed to be placed in these facilities, by and large, there's always those exceptions to the rules, but in generally speaking, that the state places kids in a group home or an RTC if they are court ordered there. They typically, unless you find some kind of private group home who's outside of this realm, typically you're not going to be able to place a child in a group home or an RTC on your own. At least not generally speaking within the WISA organization around the state. And that's important because a lot of these kids that we're talking about in these families are those who qualify for Medicaid. They don't make a lot of money. And so really they're not allowed to put kids there privately as far as private placement. The only option for them really is a crisis shelter or perhaps a PRTF. So they're moving down to a PRTF. You can see who is the payer here. And the payer, by and large, is either going to be Medicaid or it's going to be private insurance. And the reason that it's Medicaid or private insurance and say not the state, as far as paying for that room and board, is because this is considered a hospital. This is in some respect you could call it inpatient hospitalization. So you can see here who the payers are. Again, for placement and who qualifies to go to a facility such as this, and keep in mind this is one of the most restrictive environments as far as placements are concerned. Then what you have here is the state can place kids there. They have to be court ordered, and they also have to have a psychiatric eval referral. In other words, they have to go to take a psychiatric. It's not even a psychological. It's a psychiatric evaluation, and that evaluation has to specify that yes, they are in need of this level of care. And then it gets approved to the court, and kids can be placed there. But you also see that private placements can be placed there as well. So, for instance, you might have a child who qualifies under the youth mental health waiver, and so they're on Medicaid, but they're not in state custody at all. They're not on a CHINS petition. They're not a delinquent. They're not an abuse or neglect case. So you have a child who's on Medicaid. Perhaps they're working with high fidelity wraparound, and the child then needs this level of placement, a PRTF. Well, that private placement can occur. and based upon Medicaid or private insurance. But the caveat there is again, that's one of the most restrictive levels of care. They do not qualify if you have Medicaid and you're not involved in DFS custody. If you're involved in high fidelity wraparound, all those things that I talked about, you don't qualify for a group home placement and an RTC placement because there's no payer mechanism. And that's one of the holes in our system. Finally, here you have the boys' school and girls' school. This is also, you could consider this as far as juvenile detention for those counties that have a juvenile detention facility, which is jail, essentially is all that is. And you can see the state pays for the boys' school and girls' school. Of course, the state's not going to pay for jail or juvenile detention. Well, in some respect, they are, but as far as DFS is concerned, out of their budget, they aren't. And so you can see that's who pays for that. Who gets to be placed there? It's those children that are in state custody who have been court ordered. And again, this is not for private placement, and this is the most restrictive care that we have in our state. So just going through these questions here briefly, what is good for the child and family? And of course, we as a state have already instituted policy in this regard, and that is particularly when it comes to court orders. Previous legislatures have said that courts, when considering placement of children, need to choose the least restrictive environment that will cure the problem or that will help the child out. So in other words, they follow this continuum of care. This is what we have said is a legislature, and it's in state statute that this is what courts need to consider. So for instance, if a child has not done any kind of outpatient counseling, but they've gotten a significant amount of trouble, and perhaps there are those who feel that this child needs to go to an RTC or perhaps even a PRTF. The court is supposed to look at this, and based upon evaluations and all the evidence that comes in, they're supposed to judge or adjudicate the child and place them at the least restrictive level possible to achieve. And that's really good for the child and family. That's what we want. We don't want children to be going to the most restrictive environments right away. We want to follow this continuum of care because by and large it works. Then we look at, well, what is good for the state? As far as the bottom line, you could say is really money. And you can see all the things that the state pays for. So as far as our good Department of Family Services here, you can see they pay for a lot of things. A lot of things come out of their budget. You can see the Department of Health is going to be overseen as far as the Medicaid portion when it comes to different things. But what is good for the state? Well, again, these middle rungs here, an RTC placement, a group home placement is going to be a significant amount of money. So for the state, of course, they're looking not only for the good of the child, and they are, but they're also looking at their budgets as well. And so if they can place a kid at a less restrictive environment that costs less money, or if they can place them at a PRTF, which doesn't come out of their budget, or if they can place them at the boys' school or girls' school, which by and large has fixed costs, then it's going to help their bottom line. Then we look at, well, what is good for the facility? Well, depending on the facility, you can see here, as far as crisis shelter, group home, RTCs, if for instance, a group home or an RTC, if they don't get, if the state isn't referring kids and the courts aren't court ordering kids to their facilities, it's going to hurt their bottom line. So anytime the state talks about cutting back, particularly at group homes or RTC placements, that's their bread and butter. That's their only source of income is those referrals that they get. And when the state, for instance, in budget cuts or budget reductions like we're looking now, says, hey, we're going to look at perhaps more things that we can do in prevention. We're going to look at alternative things that we can do instead of placing kids at group homes or RTCs. Well, then you're going to have groups like WISA come because you're pulling on their big toe. You're hurting their bottom line. And so, what is good for them? Well, they want to get as many placements as they can, but they also want to do what's good for the kids as well. I think it's just important to recognize these things, and this is why I'm bringing this to your attention. is because you can see there's different, I don't want to call them conflicts of interest, but you can definitely see here that what is good for the family and what is good for the state and what is good for the facility aren't always the same. And so you're going to have these competing interests, and that's good for policy makers to understand and to realize, because ideally what we should want is we should want what's good for the family and the child. But these other competing interests, you know, we're going to struggle with this, particularly when we have low revenues and we're looking at how to, you know, when DFS or the Department of Health are looking at how do we go ahead and you know, save a little bit on our budgets. Well, hey, PRTF placements cost a lot of money. And in the Department of Health, they might say, well, hey, if we can increase more RTC and group home placements, then hey, that saves our bottom line. DFS is looking at it and saying, hey, wait a second, if we can not have as many group home placements and RTC placements, if we can put them to PRTFs or even the boys' school and girls' school, then it saves our bottom line a little bit. So you see those competing interests. And the last thing here is problems that arise with moves in the continuum of care. And this is important because things aren't cut and dry in the mental health world. For perhaps you have, let's say, a child who's on Medicaid, they're on the mental health waiver, they're not in state custody, they're at a PRTF, and the psychiatric residential treatment facility who's evaluating this child comes to the point and says, you know what, they no longer meet medical necessity to be at our facility, and they need to be moved to a lower level of care, right down this continuum of care, a lower level of care, meaning an RTC, a group home, or perhaps some community prevention. Oftentimes they're talking about an RTC or group home. They're not talking about sending them home right away. But the problem is they don't meet medical necessity to remain at a PRTF, but they're a private placement and they don't qualify for an RTC or a group home because there's no payer mechanism. So in other words, this child is still having problems, probably could benefit from a more restrictive environment like a group home or perhaps residential treatment at an RTC, but they don't qualify because they're on Medicaid. The only way that they would qualify to go to a group home or an RTC is if they end up in state custody somehow. And that's one of the problems that you have within this continuum of care. And so it's a hole. These are gaps. These are gaps that I've talked about before. So I hope that wasn't as clear as mud, and that kind of frames things for you a little bit. I think the important thing is there's lots of different payers. There's lots of different ways that kids can be placed. You have the continuum of care, and then you have the, you know, this least restrictive to most restrictive, less expensive to more expensive. And you have all of these things kind of coming into one. So when it comes to crafting policy, it can get hairy real quick. And these are the competing interests that we have to consider. So that's all.
Very good. Representative Clem, this is an awesome graph. I think it's extremely helpful, but I do think questions are building up. Representative Barlow.
Thank you, Madam Chairman. And I think Representative Clem mentioned this, that we just need to verify a couple of things about the IEP and a couple of the payer sources, just to make sure that we're accurate there. And I appreciate that. The one thing I guess that this points out to me is we've had this discussion in other Medicaid state type things, but when I go down to what is good for the state and what is good for the facility, at least the way I read this and the way I think I've understood it, and I think it's been reflected by Representative Clem, is that group homes and RTC and crisis placement, quite honestly, are state functions because we are basically the ones funding these facilities. So if we believe in the service, whether it's good for the facility or not, they're the ones providing it. And I think they're mostly nonprofits, so I don't know that there's a profit motive in it. But so, you know, what's good for the facility, good for the state, I think that becomes a little more convoluted depending on the primary funding mechanism of the facility. PRTFs, they may be private, they may be, you know, nonprofit, they may be for-profit, etc. I can't speak to that. But I do think that there is a really strong nexus between the state need or the state interest and the facility availability. Because if we don't fund them, availability, I think, is what is jeopardized. And that, of course, it impacts the family and the child. So the other thing I would just ask about is a couple of years ago, and this is probably 5 years ago, I think this was when Representative Larson and Chairman Wilson and I were all on the House side, and of course, Chairman Scott on the Senate side of Labor Health. We did something with Medicaid, where we allowed hospice care to pay for the state portion of placements. The federal government wouldn't pay for that, but we gave half per diem, if you will, or half rates for hospice. And I wonder if there's an approach there that actually helps with this, the state Medicaid component, where you have the red and white, yes and no, where you could maybe at least leverage the state portion of Medicaid if it's available to help with those placements. So anyway, just a couple of thoughts and maybe some feedback on that nexus between the state's interests and the flat out availability of facilities. Thank you, Madam Chair.
One thing that I want to put in kind of in alignment with one of Representative Barlow's first remarks is, I think actually on the farthest right column, private placement RTCs, I think that's not entirely correct. I know NSI up in Sheridan, which I would think falls under the RTC placement. It's a residential facility and they have counseling and that kind of thing. You can place people there privately. The only thing is that it's not cheap. So, it's available, but you have to be able to cough up, I don't know what the annual fee, $30,000 a year or something like that. So I think it's not that you can't, it's just that most people can't.
Yeah, Madam Chairman, if I may respond, and you're correct. So, and it is a mix, right? That's why it's not all cut and dry. These are all generalities. NSI is last I knew, was a for-profit facility. By and large, the rest of our facilities around the state are nonprofit. And you're right, they actually get a lot of kids from other states. They take out of state placements. For instance, in the past, they've taken a lot of kids from California. And it is important to highlight what Representative Barlow said as well. When you talk about this, is particularly when you talk about crisis shelters, group homes, and RTCs, we're really talking about our social safety net for our adolescent population and thus our families as well, and extremely important. And so if these places aren't funded or aren't funded adequately, you're going to lose beds, you're going to lose facilities, and then you're going to have some real problems on your hands. Particularly, that's going to roll over into our judicial system. It's going to roll over more into DFS. I mean, it's going to compound the problems.
Okay, I think Representative Stivar has his blue hand up. Sorry, it's a little hard for me to keep the participants on the screen with the chart, although I really value the chart. Representative Stivar.
Thank you, Madam Chairman. I was just on the phone. I've got some experience in this on both sides of the house. But my understanding is the school district, doesn't matter who places it, has to pay the 8-hour school day. There's a few kids in one district. The district's paying for everything for the boys school right now. We've got to keep this funded. This is a good chart. Don't agree with all of it. Thank you.
Thank you, Representative Stivar. Okay, Senator Schuler, are you ready to add to this or put in your separate part, however that came?
Madam Chairman.
Senator Scott.
Madam Chairman, I apologize for having to interrupt there, but I cannot figure how these blue things work. Somehow they get knocked off of my ability to use them. Anyhow, I would say this chart is extraordinarily valuable, especially with Representative Clem's explanation, because he knows the detail that the chart doesn't show. But for communicating with those of us who are laymen, this has been extraordinarily useful. I would hope that we could get the subcommittee and whoever's staffing it to get this and the explanation down and available for distribution. I would have some questions on some of these. It sounds like Medicaid can pay for some of the treatment, even though they're shown as not a payer because they can't pay the basic charge. And I think that would be a very useful addition. And the question I have, when you look, for instance, at the RTC placement, the two possible payers are both 100% state. State being, I think, DFS in this case, and education, that's 100% we're paying, and you might as well be general fund. It's competing with the general fund. We're paying half of the Medicaid for a more expensive PRTF. Is the state paying more or less for a PRTF placement or an RTC placement? That was a question that jumped out at me when you consider the various sources. Is there any qualification on that sort of thing?
But Mr. Chairman, I am not an expert on this, but I'm going to say what occurs to me, and I can be corrected perhaps by one of the presenters, or if we've got Department of Health or DFS on, but I think that the RTC is probably a little bit kind of like the assisted living, in the sense that the state doesn't pay for the residential room and board component, but Medicaid will pay for whatever healthcare type thing. So in the case of an RTC, I suppose Medicaid would pay for, counseling, maybe if the child needs some sort of psychiatric medications, the doctor's visits, that kind of thing, similar to assisted living facilities. That would be my thought, but I can certainly be corrected. Looks like Representative Clem is ready to say something.
Yeah, Madam Chair. I mean, you're on the right track there. Again, we're talking, and that's where, this is, while the chart is helpful, it's not cut and dry. I just really need to emphasize that is there's these nuances and there's these intricacies about it. But as far as the placement is concerned, the state is paying the room and board, and they're paying a per diem rate. Last I checked, I think it's either $175 a day per kid, right? So whereas in a PRTF placement, it is coming out of it's coming out of Medicaid funds, and that depends. That's $50. So for instance, if the per day rate is $250, then it's, you cut that in half, it's $125. So in some sense, I guess you're saving some money. But again, one of the things to keep in mind is that's the most restrictive level of care. That might be good for the state as far as less amount of money, but it's not good for the kid. It's not good for the family, because we're talking about the most restrictive level of care here. So that's where we just have to keep in mind these competing interests. And our Department of Health and our Department of Family Services really pay attention to this. I mean, they are for kids and families, and they are looking at, so when a child no longer meets quote unquote medical necessity at a PRTF, they need to be moved to a lower level of care. It's just, what is it? What is recommended? And then what do they qualify for based upon their custody, whether it's state custody or private placement, or if they're, on an IEP. Those are just some of those things to consider.
Senator Schuler, are you up?
Yes,
thank you.
Sorry, Senator Scott, did you have another question?
Yeah, a follow up on that particular last thing. I have heard considerable complaint from our local psychiatric hospital, actually, that it is very difficult to find a residential treatment center in Wyoming that we've managed to kill all those off for, I suppose, for financial reasons. Is my impression there accurate, that we've done some things that may be foolish in terms of being able to treat the kids and treat them in a less restrictive environment, possibly because of the finances here?
Madam Chairman.
Representative Clem.
I think what the problem that you run into is these gaps. If a child is in DFS custody, or perhaps they're on an IEP and directed to go to a lower level of care, they're at an RTC, and then they're recommended to go down to a group home level of placement to transition back to their family, let's say, or maybe they need to go to residential treatment where they have more intensive treatment, inpatient treatment, in an inpatient environment. The problem is if you're on the Medicaid mental health waiver and you're on high fidelity wraparound, you're a private placement and you don't qualify for the group home or an RTC placement because the only payer is the state and they don't take them. So yeah, that's where the gap is. We have 3 or 4 RTCs around the state. You know, we've got NSI, we've got the Yes House. We've got, I think Cathedral Home in Laramie. We've got another one, I think, over in Jackson. So we have them around the state, but as far as them taking private placements, I can't tell you how many times as the coordinator of the group home when I worked at the Yes House, I'd get referrals from PRTFs, kids who were on the Medicaid waiver. I'd have to ask, hey, are you in the legal and physical custody of DFS? You know, no, we're not. I'm sorry, we can't help you. And that was it. And so, you know, unless they get in trouble or go into a CHINS petition and the state then gets involved, which is more time and resources and money, you know, they don't qualify for these other services. So it's a gap.
Or again, as I say, and I only know with the NSI situation, if the family can afford to pay, you know, $20,000 or $30,000 a year, which is hardly anybody. But I mean, I'm, you know, but yeah. Okay, Senator Schuler. Oh, I'm sorry, Representative Stivar has a question.
No, I just have a comment. Again, my experience, but it also depends on the insurance company. I know an insurance company that actually did pay for an RTC placement coming out of a PRTF. So, you know, there's a big gap there because it's, Mr. Clem's right.
Okay, let's Senator Schuler talk.
Thank you, Madam Chair. I don't know that I need the chart or not, but you can leave it up if you'd like. But so I appreciate all the work that Representative Clem did. I had quite a nice visit with DFS with Director Schmidt and talked a little bit about some of the issues that we were having. And I know I brought forth the question earlier at one of our meetings about why are we sending so many kids out of state? And, you know, this costs the state a lot more money. The bottom line is really what I found, and obviously DFS is going to follow me up. I think Lindsay Schilling is going to do the presentation, but we really don't send that many out of state. I think it ends up being about 10 to 12 is what Director Schmidt mentioned each year. And I think these are, oh, she's on actually, so she can probably tell you a little bit more about it. But what I would like to mention is just the fact that I think when we had some presentations earlier on the youth residential services, I looked at that chart and looked at the fact that, you know, there were 11 out-of-state providers. There were only 2 PRTF providers in the state, which Medicaid and Mr. Clem, Representative Clem actually talked quite a bit about that. I was looking more about, do we have enough providers? Do we have enough folks that, you know, provide within the state that we can keep them in state? And I did talk to quite a few of the nonprofit and for-profit folks here within our state. I kind of tried to get an idea on what they charged. It's all over the place. It depends again on what type of service they're providing, you know, whether it's a chronic suicide, eating disorders, kids that have been sexually abused, personality disorders, so on and so forth. And it really depends on it, whether or not they have to detox the kids also because of drug issues. So I really couldn't get a good, summary of what the costs are out of state versus in state, because it really depends on the type of care that they need. And whether or not it's obviously inpatient or outpatient. And so I did talk to some folks in Utah with a couple of the centers down there. The majority of the places I talk with treat kids from 12 to 17. And if you look at the data nationwide, about 60% of all of our mental health costs are coming from that age group. The 6 to 11s, I think it's about 30% of our money, but nationwide, we spend about 10 billion on mental health for our students, and obviously it's a problem. So there's things in our state. I think our state does a great job, and like I said, Director Schmidt is probably going to have a lot more information. But I think we spend probably around 26 million just from DFS's, and Director Schmidt will maybe correct me if I'm wrong on that. But all of these things are important, whether we're spending money through BOCES and the Wyoming Department of Education, or whether it's group homes, boys' school, girls' school. And I did look at the statistics that we were given, and the girls' school, actually the cost of that went down a little bit in 2019. The boys' school, they're staying about the same. Our BOCES programs had a definite increase, and our group homes stayed about the same. So, I know DFS is the primary payer for our RTCs, and I think we have 11 of those in the state, 16 group homes, and 13 providers that provide crisis beds. But for the most part, like I said, I think Director Schmidt will have a lot more information than I have. But it was just interesting because I asked the question, and I know probably that's why Representative Wilson put me on the subcommittee, is why can't we keep more of them in the state? And I know that when we get someone that is a high risk, high need student, sometimes no one wants to take them, unfortunately, in state or out of state. So I'll let Director Schmidt go on from there, and unless you have questions for me.
Any questions for Senator Schuler? Okay, I think we have, is Director Schmidt? Oh, sorry, Representative Larson does have a question.
Madam Chairman, I don't have a question so much as if you feel it appropriate, would like to, could maybe make some comments back on the chart that Representative.
Go ahead. I think that will be fine. I authorize you to make comments on the chart.
And also, if Representative Clem would be kind enough to share that with us again. And Madam Chairman, I guess I would make these comments to help the committee kind of understand that this a little bit from the discussion we'll be having related to Senator Scott's question on monies.
Mm-hmm.
This kind of comes just from my both the Department of Health and DFS are committees that I have on appropriations. And let me just help this committee to understand that when you come down, if you come down that second line, foster homes, what we do at the DFS budget is we reserve a number of beds in those homes. So, and those are not in, no, excuse me, go to the third one, the group homes, is we pay for beds, whether the beds are full or whether they're not. So that's kind of a little bit of a fixed cost. If you would come back up to foster homes, and Representative Clem, this really is a nice chart, and you're right that the state through general funds pays for the placement of these foster homes, and these are court-ordered placements. They're judicial. There's not a Medicaid reimbursement. However, there is a reimbursement through through 4E, the Social Security Act, that allows reimbursement for expenses that the state has on these children if they meet certain criteria, which most of the criteria is the Medicaid type of criteria. So we provide the services, and then we can be reimbursed through the 4E process for those costs. So there is some money that can come back to the state through that on foster home. On group home, on RTC placements, and group home placements, you'll see there that we talk about state paying it, then education paying it. And I just hope that people will understand that if the school district's paying it, or Department of Education paying it, is no different than if the state was paying it. It's general funds. It's nothing, it's nothing magic that doesn't impact our revenue system. And so when we come down to the RTC component of that, this is a challenge that we've identified and put out to the Department of Education, is on the RTC place and the regional treatment centers, is DFS goes out and they negotiate a daily per diem rate for an RTC. Education doesn't. And so if a child is placed in an RTC by virtue of an IEP, those costs are significantly more for the same treatment as being received by somebody that's there through DFS. And that's kind of a wonky deal there that we think needs to become more balanced, because those costs on the education side are reimbursed through special education at 100%, and we need to be a little more economical on that. You're right, Representative Wilson, on the RTCs and the PRTF, when we say that the state that Department of Health is paying for or DFS is paying for the per diem. Department of Health is responsible for their medical costs, and education is responsible for their educational costs. The challenge that we have on the PRTFs is that if in the event they do go out of state, and it's a Medicaid payer, we oftentimes find, and we worked with, I had a situation here in Fremont County where I was working with Director Smith and Department of Health and Department of Education, where we were trying to find placement for an adolescent who was very acute and couldn't be handled in the state. But when you go out of state, some states will accept our Medicaid rates and others won't. And so then there's a negotiation. Can you take an enhanced Wyoming Medicaid rate, which has to be approved by the Department of Health, or will the Department of Health just pay for it, or DFS pay for it out of their budget? And so there are some situations that know they're in the state for out-of-state PRTFs, maybe could be a little more pink, because there is a possibility that we would have to pay for that out of our general funds if they won't accept Wyoming Medicaid costs. I would just share with you that the cost for those kids out of state in some places can be are generally more expensive, but sometimes can be very expensive. The one that we was working with, we ended up not placing out of state because he was just about to reach his 18th birthday, and we was able to place him here at the WLRC, but his cost would have been over $250,000 a year. And the only place in the continental United States that we found that would take him was in New York State. We tried all the surrounding states, Washington State, Mississippi, Texas, Pennsylvania, Wisconsin. Lindsay Schilling, bless her heart, deserves a gold star because she worked very hard to get that. And so it's important to understand that there's a real impact on these PRTFs. And to Senator Scott's point, there is a shortage of rooms in the state for, particularly for PRTF beds, and it's something that the subcommittee needs to look at. And then finally, on the funding issue, Madam Chairman, on the boys' school and the girls' school, I'd like everybody to look at that. And that yes portion there is really important. Boys' school and girls' school are 100% general funds. And so when we look at services provided there at the boys' school and girls' school, is that may be something that we need to look at. Maybe we could re-evaluate how and what services are done there, because it doesn't have to, maybe if it's juvenile detention or or we repurpose that some, that it wouldn't have to all be general funds. And I just throw that as a seed to plant in your thought process, because those are all general funds on both of those. So
I believe Representative Barlow has a question.
Madam Chairman, thank you. So I think, thank you for the summary with Representative Clem and all the discussion. The Boys and Girls School, actually, what interests me about that is what services they're actually providing, because I don't believe they're considered a PRTF. They're not licensed that way, RTC, group home, crisis anyway. So we really are talking about more of a legal process that gets folks there potentially, and not that they don't get any treatment. I'm not saying that, but it's not a licensed facility as some of the others are. Could either Representative Clem or Representative Larson speak to that licensure issue? Thank
you. And I'm sure after that, when we hear from Director Schmidt, she can tell us more. But Senator Schuler, Representative Clem.
Madam Chairman, I think Director Schmidt would be better to answer that question. I do know that they do offer, for instance, they offer different services, whether it's outpatient. For those of you who are familiar with the ASAM level of care, that dictates placement in some regard when a child goes through some kind of an examination. For instance, an RTC placement is considered a 3.5. And I don't recall what boys' school and girls' school. I think the girls' school is a 3.5 facility, but I don't want to. That's enough speculating on my part. I think Director Schmidt would need to answer that.
Right. Let's hold off for Director Schmidt on that. Okay. I don't know. It's really helpful having this chart. I don't know if Director Schmidt will find it, useful while Director Schmidt is on or not. The only challenge is when the screen's up there, I can't see a lot of people's faces. So I'm trying to watch hands, the screen, and the faces all at once. Director Schmidt, welcome back. I think we saw you yesterday.
Yes.
I don't understand how that could be.
Well, good morning, Chairman Wilson, Co-Chairman Scott, and members of the committee. My name is Corinne Schmidt, and I'm the Director of the Department of Family Services. And wow, this is a lot to unpack. And first and foremost, Representative Clem, well done. This is a really nice depiction of the system. There are some nuances in here that will make things a little bit more complicated, but with his permission, I would like to use this as a basis of what I think we'll be eventually presenting to the task force, the joint task force between joint appropriations and joint labor. And what we can do is fill in many of the blanks maybe that have popped up today. Some things to go to this chart, and then I'll get to the boys' school and the girls' school in a minute. But one of the things to remember specifically about the state as it's listed on this particular graph is what that means is that a child has come into state custody. And there's three ways to come into state custody. It's either through an abuse and neglect petition, it's through a child in need of supervision petition, or a juvenile delinquency petition. And so once a child comes into the custody of the state and then is placed with DFS for custody, that child is Medicaid eligible. And I think that will help explain in some ways why the state is paying for some things and not others, because oftentimes that will depend on what Medicaid pays for and what it does not. And that gets a little bit to the RTC and the group home situation. So when a child comes into custody, foster care is always the place we look first, and family foster care being in a home. We think that a child deserves to live in a home setting. But we know that's not always possible. So if there isn't a home setting available, then we start to go through these different levels of care, basically starting with group homes, residential treatment centers, PRTFs, the boys' school and the girls' school, detention a little bit separately from the boys' school and the girls' school. And then there's also an acute psychiatric care placement that we use that's not listed on here. And again, those are nuances and really not important for this conversation. But essentially what happens then is when we place, then different funding sources kick in based on a law called through the court ordered placement law. So we'll get much more into detail of that when it's our turn to present in a larger context. But the custody is important because that will dictate so much of what and how happens later on. Custody can be placed by an educational, a local school district in a BOCES as well. And then there's the private placements parents can place. And when parents place, those child may have private insurance or they may be Medicaid eligible. So it gets pretty messy. In regard to the budget, our budget is largely going to out-of-home care. About 75% of our budget goes to out-of-home care. Of that 75%, and when I say budget, I mean the budget for child welfare, juvenile delinquents, and children in need of supervision, not the larger agency budget. So about $24 to $25 million a year is what I'm talking about. Of that, 75% is out of home placement. Of that 75%, about 25% is for family foster care. Let's see if I got that right. Yeah, and then 75% is for out of home in what we call a congregate care or youth facility. So when you look at our local services budget, about half of it goes to some sort of congregate care placement, and about 25% of it goes to family foster care. So to get to Representative Clem's original conversation around the tension between good for the state, good for the child, good for the facility, that's a very real tension because there is a good portion of our dollars that do go to some sort of out-of-home placement. A quick note on that, prior to COVID, we were heavily working with our community, our youth services providers, the Wyoming Youth Services Association, around our group home placements. We recognized early when we started talking about some other things that access is an important issue to the state, and it's important to DFS. We need to have those services available to us when we need them. The issue is that the facilities also need to maintain a certain level of census in order to fulfill their obligations and to operate. So where the tension comes in is we don't always need a group home, but group homes are always going to need to have money to stay open. So the short of it is that we've been talking about looking at more of a fixed rate contract for group homes, so that they know that they have operating funds coming into their facility and that we know we always have access. We can't afford to lose any group home placements. We do use those, and we wanted to ensure that we could have access and at the same time that the individual providers also have resources to provide the service. But as part of that conversation, we're also moving into what Representative Clem suggested was around a more community-based idea. So in our conversations about group homes, we're also having conversations about what we can do to help those Youth Services Association members and any of the other providers to move to a more community-based sense of care, meaning where are the families coming in when a child is placed in a group home? What's the interactions with families? What's the work that's being done in order to engage the family so that placement can be shorter, but that the family is better prepared and more able to take care of their children at home. And then in the middle of that comes crisis too. We do pay for crisis placements. It doesn't matter if the child's placed by a parent, by a community, or by us. Representative Larson is correct. We pay for the service as a whole, whether the bed is being used or not. So lots of, the short of that is we're having really good conversations with our stakeholders and our providers around what we can do to reinforce the system, but at the same time also looking at what we do to reinforce our family system so children can stay safe at home. The last point is around the boys' school and the girls' school. And the boys' school and the girls' school is a little bit of a different animal than what we see in other parts of our system. It is not detention. Because it is not secured, it's not locked. So the children, the youth that go to the boys and the girls school are there because of a juvenile delinquency petition. That service is only available to children who have been adjudicated as juvenile delinquents under Title 14. So it's a fairly limited population. A county sheriff can't place there, a county attorney can't place there unless a juvenile delinquency petition has been filed and the court orders the placement of that child in the boys' school or the girls' school. It is 100% state general funded. We get a little bit of federal dollars through various sources to provide some special ed services. The services that are provided for mental health and substance abuse treatment are provided by local providers that come onto campus and provide those services. So those services are actually paid for by Medicaid. And then Medicaid, however, is not able to get federal reimbursement for those dollars because in Medicaid's eyes and CMS's eyes, it is a correctional placement, and so it's not eligible for federal reimbursement. So Medicaid is still the payer source to those outpatient services provided on the campus. Medicaid still pays for those. The billing all occurs through Medicaid, but Medicaid's not eligible to draw down any federal match. And that's a pretty important distinction for a conversation that we'll have later. Juvenile detention is more often either run privately or by counties. And that is a detention system that's usually part of an adult jail. The counties pay for many of those services. DFS will pay for juvenile detention if the juvenile court orders a child to detention. So again, many nuances, but I think I hoped I hit on most of the important conversation that popped up as a result of this. It is very confusing, and it really relies on so many factors of the child, who's placing, and eligibility, and what services each of the programs can provide. So at this point, I'm ready to turn it over to Lindsay Schilling, who's going to talk a lot about out-of-state placements. That was the conversation that we had with Senator Schuler, is to really think about what those out-of-home placements are, but out-of-state placements are. But to tee it up, where we fall short, I think, in our system is that we have some extreme needs. We have children with incredible complex needs, with behavioral issues, with intellectual or developmental disability issues, with mental health issues. And oftentimes DFS ends up being the safety net. Oftentimes parents come to a place where they don't have private insurance anymore. It's been fully expended, or they never did to begin with. And so they request assistance from the court places in our custody, and then it's up to DFS to find the services for those children. And so we work whatever network we have. We work through Medicaid. We work through our providers here in state, our residential treatment centers, our group homes, our PRTFs. But where we get to as a system is that everybody gets to tell us no. We have a child that we're looking for a placement, and all of the facilities can tell us no. And they don't do it because they're mean-spirited. They do it so many times because they just don't have the services available to provide the child, whether it's a very high need child that needs a lot of supervision, like Representative Larson had suggested. You know, we've searched high and low for a facility, found one way out of state to the tune of $275,000 as a starting point. And they get to decide whether that child comes in. What we don't have is what the adult system has, and that's that final safety net. There is a final safety net through Title 25. Who and how and how it works isn't really the issue that I'm concerned about. It's just that the state hospital or one of its ancillary service providers will eventually have to take a client, whereas we rely on our private system and the ability that they have to have the resources they need to serve that child in order to finally get that child into services. The result is sometimes our kids go to jail. They go to a detention facility, which is extremely tough because they did nothing wrong, but there's nowhere else that we can keep them safe. So with that, I'm going to turn it over to Lindsay. And if you have any questions, certainly I'll stand for those. But I think Lindsay will be able to give you a little more sense of kind of the back end of the system where we just face the biggest problems and have to do the most to work with our community partners, our agency partners, and especially the families. So Lindsay.
Great. Yeah, let's if there are questions for the director, let's hold off until after Lindsay presents, just in case some of them end up being answered. Go ahead, Lindsay.
Thank you, Madam Chairman and Director. I do have some slides to present.
Go right ahead.
I think there we go.
Do we have these slides as well? Did they get sent to us?
I don't believe so, but we can certainly provide them after.
That would be helpful.
Absolutely. Okay, Madam Chair, my name is Lindsay Schilling. I'm the Senior Administrator for the Social Services Division at DFS. And what we did for today's conversation is to collect updated data on our out-of-state placements. We worked also with the Department of Education and the Department of Health to bring in data from those two agencies as well regarding their court-ordered placements and private placements out of state. So we just wanted to provide those updated numbers. And then if the committee is interested, we did also prepare additional data on this high needs cohort of youth that we are seeing come through the DFS system. And I have some information available on that as well. So when we're talking about adolescent and children's behavioral health placements from a DFS perspective, the facility types that we're referring to are illustrated here. As it's been discussed, crisis centers are sort of a blended funding arrangement, but on the DFS side, we do provide a per diem $117 a day, but that is it's matched 50% by federal funds. So our payments to crisis centers on average are 50% state general fund, 50% federal fund. Group homes, we also have our BOCES providers, RTCs, and then the acute psychiatric stabilization, usually done through psychiatric hospitals or general hospitals with psychiatric units. And then of course, PRTFs and detention facilities. We also wanted to take an opportunity. We received several questions and requests for clarification on the May 29th related presentation. There was a chart related to the facilities and available beds. We just wanted to be sure and point out that the numbers that were shown on slide 32 in that particular presentation were simply meant to represent capacity. So if you take the number of licensed beds in all of the participating facilities, that was the total number of beds represented. That number was not representative of actual utilization or payments that either agency had made to those facilities. So updated on the DFS side, costs of mental health and substance abuse placements. I went ahead and included 4 years of data here, illustrating the total number of placements, the number of placements we had in state, the number of placements we had out of state, what our total payment was in aggregate for the whole year, and then what our payment was to out of state providers. So I think as you'll see, this data supports what Senator Schuler had mentioned before, that in reality, the proportion of our placements out of state are very low in comparison to the total placements in any given year. These out of state placements, however, tend to be the most challenging and can be at a higher cost to the agency. So on the DFS side, when we're looking at our drivers of out-of-state placements, aggressive behaviors and low IQ, a current network that doesn't have the clinical capacity or the physical plants to accommodate these youth. So a lot of times we have youth that need one-on-one supervision. They need locked units, single rooms. Just from an infrastructure perspective, our facilities aren't equipped to handle some of those needs. We're also running into more and more issues around the age of the youth and facility licensing. A lot of our facilities are licensed to take older youth, and we're seeing an increasing number of younger children needing placements earlier, and that becomes an issue with facility licensure. And then specialty programming needs. Data provided by the Department of Health and Medicaid. Again, the trend is similar. They've provided us 4 years of state fiscal year data with the total number of placements, in-state placements, out-of-state placements, and then the total aggregate payment for that service. Again, you'll see that on the PRTF side, even through Medicaid, the out-of-state placements are really not the majority of their placements in totality. But again, when querying their clinical units on the reasons kids go out of state, there's a lot of common trends. Facilities in state are unable to manage the treatment and behavioral needs. There seem to be quite a few lateral transfers between facilities in state before a child would be considered for out-of-state placement. Aggressive behaviors. And then geography was actually one that came up on the Medicaid side. Simply when you get to some of our towns and locations where those children live, the closest facility that offers treatment is an out-of-state facility. So the placement determination is made just to use that facility closest to their home community. From the Department of Education, they were able to provide us both information on their court-ordered placements for biennial fiscal year 2019. So these numbers, it's actually a 2-year figure. The court-ordered placements would have been children in DFS custody. So there were 27 that they made payments for educational services totaling 1.2 million. These medically necessary placements are PRTF placements of children not in DFS custody. So this is the other placement arm of Medicaid where they're supporting Medicaid children with no DFS involvement. There were 30 of those placements, totaling $1.1 million. And that's what we had just on the outpatient data side. I'd be happy to move into the more detailed information on the high needs cohort, if that's of interest.
Are there any questions specifically about these last couple of slides? Because I can't see all of you, use your blue hand unless you're Chairman Scott. Okay, go ahead, Lindsay.
Okay. So after the May presentation, what we were able to do was to go back and pull up additional data based on the clinical reviews that our clinical unit did. So we have in DFS a team of 3 licensed clinicians that really help support needs in the field in terms of identifying appropriate services. They do a lot to support placements, helping to find appropriate facilities. They work hand in hand with the Medicaid team and Optum with the prior authorization process for any of the kids in custody. So they have started tracking data for us just related to these really complex cases that we are encountering. So in the last 18 months, we now have 14 cases. I think in May we talked about 12 cases. On average, these kids are 15, but they range in age from 10 to 18. Again, diagnoses of aggressive behavior and violence. 6 of the 14 were dual intellectual or developmental disabled children. Entry into DFS custody. So all 14 of these kids that our clinical unit supported did come into DFS custody. 50% of them came through a CHENS petition. So these are families that are looking to DFS, as the director said, as the safety net or kind of the last option to find help to support treatment needs in these children. Of those that came in through the CHENS petition, 4 of them eventually transitions to a juvenile delinquency petition. So what happens is we have troubled kids that come in through a CHENS, they act out or offend while we're working to try and find placement and supportive services. And then they end up down a delinquency path because we weren't able to secure services, or services weren't available, or just simply there wasn't time to intervene in that particular situation. Of these 14 kids, 10 of them were determined clinically to require an RTC or a PRTF level of care. 3 were actually requiring acute stabilization, and 1 required a BOCES placement. The outcomes are really, I think, what causes us the greatest amount of concern when looking at how we're supporting families. Of these 14 children that came into DFS custody, 9 of them are not currently in a placement that meets their clinical treatment need. So we've been unable to, for a variety of reasons, find an appropriate treatment facility to provide those services. 8 of 14 just ended up being discharged home with a safety plan in place. Several later decompensated, where then they showed back up on the Title 25 side or in the corrections system. We have 1 that went to the state hospital, discharged, and is now incarcerated, 1 in juvenile detention, 1 at the Life Resource Center, 1 at BOCES, and we still have 4 waiting for placement. These children that end up sort of in a spot where they continue to wait for appropriate treatment end up acting out many times, and then we see them transition over to the juvenile delinquency system. Involvement in other systems, so all 14 of these cases, many of them had prior placements before their involvement with DFS, so there were attempts by other state agencies and entities to intervene and provide services or educational placements. So we have evidence that the districts had tried to intervene and support services and were unable to find services. As these kids are aging out of the welfare system, we're watching them spill over into the Title 25 and correction system. So then again, I think, and this goes back around to the information provided by Representative Larson, in our root cause analysis, comes back to there being no facility safety net for pediatric psychiatric patients in Wyoming. So unlike the adult system, we have state hospital and Title 25. We have no state facility obligated, or any facility to accept clients for treatment when they're under the age of 18. They're all private and they have the ability to decline admission. So I think what we see as our greatest need from a policy perspective is to establish a clearly defined safety net for this particular cohort of youth. And that involves exploring opportunities to do that with some of our private sector providers. We've received interest from several of our current providers in network, and or leverage opportunities within existing state agency infrastructure. And I know that Stefan, Deputy Director Johansson, talked yesterday about some of the potential ideas. They were looking at the Wyoming Life Resource Center, and they've been collaborating greatly with us just in brainstorming different options that might be available for, proposing solutions to this particular issue. And that's all I had for you today, Madam Chairman.
Great, thank you so much. Okay, so if we have questions for Director Schmidt or Ms. Schilling, raise up your hand now. I see Senator Scott.
Madam Chairman, question for Schilling, Ms. Schilling, on the acute psychiatric side, the facility here in my county, WBI, closed a juvenile facility for economic reasons. Is that problem continuing? Did that cost us our safety net, or a portion of our safety net? Because I think they bluntly said the state reimbursement was such it was not economic to provide the full level of treatment facilities that they had been and they closed one of their units. Is that what we're seeing here?
Ms. Schilling.
Madam Chairman, Senator Scott, in speaking only to the 14 cases that we've reviewed clinical files on, that was not the case. These were situations where there was bed space available at our in-state facilities, but the clinical milieu required to keep those children safe was not something that they had constructed on site. And I think in sort of going back to the May presentation, Emily Genoff spoke a little bit to that, just in the fact that the cost involved with constructing a special treatment program for the 1 or 2 children that might come along in any given year that would need those services just wasn't something they had been able to take on.
Senator Schuler.
Thank you, Madam Chair, and thank you so much, Lindsay and Director Schmidt. Answered a lot of my questions that I had. I appreciate all the information and the time you put into that. Couple questions. First of all, and I know I've brought this up a couple different times, and I know you're looking at maybe the Life Resource Center, but again, in looking at the state hospital, we still have a couple of decent buildings over there. In fact, the one building where they used to call it the State Hospital School was housed is still in really good shape. If we really need something like that, it might be worth taking a look at that as well instead of having to build something new. And again, I was told it was a staffing issue as to why that went away. But again, if it would be an option to look at, maybe we should look at that as well. My question, I think, would be for either one of you on you talked about the possibly doing a fixed rate with the youth services. Could you talk a little bit about that, or maybe, just a little bit more elaboration? Either one of you.
Ms. Schilling or Ms. Director Schmidt?
I can take this one. Thank you, Madam Chairman, Senator Schuler. So this conversation started a little over a year ago and has been, like everything else, delayed because of COVID. But what we recognize that like Wyoming recognizes with healthcare services is that we just don't have a lot of numbers or a lot of need to really support in a utility standpoint the services that we have to have available to us. So there's been a continual conversation between the department and the Youth Services Association and the providers for many years about this idea of about a daily rate. When we reimburse on a daily rate, we need to ensure, or they need to ensure, that they have a set number of children utilizing those beds so that they're bringing in enough revenue in order to keep their operations going. And what we recognized quickly after our conversations last year is that some of our providers really are operating on a very shoestring budget. And so the difference between a placement and not getting a placement can mean a lot. So rather than trying to look for ways to get kids into their facility, because if a kid doesn't need that level of care, then they don't need that level of care. We wanted to talk to them more about a set amount, kind of a fixed price contract, so to speak, to say we need access to this service. Instead of reimbursing you on a daily rate, we're just going to do basically a fixed price. And then you will provide us with those services. And then we need to negotiate what that means. So, how many kids will you be able to serve? What will be the conversation around high needs kids and who they can feasibly take and serve versus who they can't. And then more important to us as an agency was really about the types of services that are being provided while a kid is there. In a group home specifically, what's the outreach with? We're very much interested in the outreach to families. We're very much interested in looking at ways that those providers can support the family so that children can return home. Again, with the general premise that we believe a child, if they can be safely at home, that's the best place for them. So it's a little bit about reinforcing the system for access purposes, but which gives the providers a predictable income so that they can in turn think about the services that they're providing rather than about how are they going to keep their doors open all the time. And then we can start to move all of the system then to a more community-based system, which is where those crisis beds are really important. Those crisis beds, anybody can use them. A child doesn't have to come into custody in order to access those crisis beds, which is what we want, right? We want that available. If a child needs a timeout, we want that to be available. We don't want to have to get fully involved in a family's life in order to bring them into care just to get them into a group home. That's not fair to the family. It's expensive for the system. And quite honestly, it's doing nothing to support the family in the long run. So it's really about looking at our model. It's a financial structure in order to incentivize moving the system a little bit more into prevention orientation, but at the same time, providing the providers with consistent funding so that they can always continue their operations, because there are times where we absolutely need those services.
Representative Barlow.
Thank you, Madam Chairman. So I'm getting the impression that we're seeing and maybe it wasn't direct testimony, but are we seeing a trend in increasing complexity of cases, both in medical and mental health, pure medical and mental health, and other, I guess, primary needs? Are we seeing that as a trend, one in complexity, and then two in numbers? Are we seeing any trends, not COVID related, just over the last 2 or 3 years that the DFS is seeing? Thank you, Madam
Director.
Madam Chairman, Representative Barlow, this is my anecdotal evidence for you. So we can go back and look at the data and see exactly characteristically what's happening. But my sense is that we are doing better with prevention, right? What is really coming to us are those 12 to 14 cases in any given year that are just extremely complicated. But because we've developed some other ways to serve kids up to that point, that the energy and time really just starts to focus around those. Those kids have always existed, but I think that to some extent they've gotten lost into the larger population that was also going into a lot of placements or going out of state. Now that we're better to serve a lot of those kids within our state or within our communities, we're really hammered with those complex. I do have to say, I think the Children's Mental Health Waiver, which turned into the care management entity, has been a big contributing bonus for us, at least from the Department of Family Services side. We've seen less kids have to come into the custody of the state because there is a children and adolescent mental health system. While it's not complete, there is a system for them to go into so that parents don't have to give up custody. So I think we've been complementing the system in ways that what we now have are just really complex cases.
More questions? Director, the thought I had is, at the end of Lindsay Schilling's presentation, the discussion was sort of the need for, basically a pediatric safety net. But then picking up on your comment, which we have noted elsewhere on the more physical health side, is we don't have a lot of volume in this state. And so as much as I understand how we would want to have high needs children close to their parents, I'm also wondering whether that's really realistic. We don't attempt to set up a pediatric kidney cancer specialization program in the state, or, there are so many things for which we just assume that the child will have to go to Denver or Salt Lake or something like that. Have you, in your discussions with, I know while you're calling around trying to find a placement, it's probably not what you're having this discussion about, but I would assume that many of our neighbors, which also have lower populations, some of them anyway, have a similar volume issue. What discussion has there been about kind of regionalizing some of the severely mentally ill pediatric patient treatment type situation in such a way that the states could have some sort of contractual agreement that they would be the safety net? The only thing is the safety net would maybe not be in our state. Has there been any discussion along those lines?
Madam Chairman, not with other states specifically. I mean, we become familiar with other state systems because we utilize providers that happen to exist in those states. But in terms of a direct conversation, for example, with Montana about this youth population, no. But I do know that Montana did have a facility in Boulder that served to some extent as this type of safety net. And they had, they made a big push to close it and really did, you know, it was that idea of deinstitutionalization. But what they found is where we are, they still had some kids that really needed that level of care. And I think we touched on it a little bit. And well, you just touched on it. You know, there's so many different needs. It's not a large population that I really think it comes down to a policy decision the state needs to make. You know, is it important to us to have that safety net? Is it important for those children to stay in state? And if so, what's the best way to provide that service? Whether we utilize one of our state campuses, boys school, girls school, state hospital, life resource center, is that a state function? Should the state be the one that's responsible? Or do we work with private providers and somehow reinforce their system or their facility so that they are able to take those kids at any time? What we need to decide is if that's how we have the option of doing nothing as well, and nothing meaning status quo. We could continue to look as those kids come through our system. We could continue to focus a lot of time and energy and resources in finding them an appropriate placement. But it's tough. It's tough to, you know, to talk to a family and say, we think the only option we have for your child is jail, because we can't find anywhere else for that child to be safe and for your family to be safe. And that's what gets tough.
If you do find an appropriate placement, what is and I appreciate that with 14 kids, they're all probably very different, but if you can give me a sense of what the average length of stay would be. I mean, are we looking at trying to place kids for 30 days or 2 years until they turn 18? What usually is the situation?
Madam Chairman, it depends. And Lindsay, if you have data on average length of stay for any of those youth, please pipe up. But sometimes, you know, at the age at 15, we're starting to look at what happens to them as adults. So that becomes a pretty intentional placement too, depending on how old they are. We may be able to place them somewhere where we can get by for a little bit so that when they turn 18, we do have a Title 25 option available to us. And that's happened just as recently as 2 months ago. We did our best to find what we knew was a temporary placement. And it wasn't one temporary placement. It was a series of temporary placements until that youth turned 18. And then we could say, okay, now this person is of harm to self or others, and they qualify for Title 25, and now they can go to the state hospital. And then that length of stay questions, you know, is turned to them. How long do they stay there?
Any more questions? So who has an answer? Oh, no. Representative Roscoe. Representative Roscoe has an answer. Go ahead. Go ahead.
Thank you, Madam Chairman. I don't have an answer really.
Okay.
I was just hoping that maybe Ms. Schilling could explain to me a little better what a BOCES facility is and where we have them in the state.
Ms. Schilling.
Madam Chair, Representative Roscoe, Corin might have to help, but BOCES facilities are the Board of Cooperative Education Services. So they really end up, it's an educational placement that's funded by the local regions. And a lot of the clients they serve on our behalf are developmentally disabled or intellectually disabled children that have some psychiatric or mental health component or behavioral component. I think most often those are educational school district placements, but we do use them for some of our children as well.
Madam Chairman, Representative Roscoe, there are 3 BOCES that we use. You know, BOCES is a little bit larger of an animal, but the 3 that we use that do have placement services are CBAR-B in Jackson or Wilson. There's one in Thermopolis, and then there's one in Gillette.
Senator Scott, did you have your hand up?
Yes, Madam Chairman. Technical question on the Title 25 that Director Schmidt was talking about. I understand the state hospital won't take a Title 25 until they reach adulthood. And I understand that. Are the juveniles ineligible for Title 25, or is the problem that the state hospital won't take them so that you don't solve the problem?
Dr. Schmidt?
Madam Chairman, Co-Chairman Scott, yet adolescents are eligible for Title 25. There can be a court order that says danger to self or others. So it's just another court proceeding like a juvenile delinquency or a child in need of supervision. The end result really isn't any different than what we experience already. It's the lack of placement. So the state hospital, for a lot of reasons, doesn't take youth. You know, we've been under lawsuits. The Chris S. lawsuit was something, there really was a deliberate part of the state to say we really shouldn't be serving children at the state hospital. But the conversation, I was not around for those conversations, but I don't know what the conversation was about then, so what? If we don't place children at the state hospital, where do they go? And I think, you know, our provider system has done a great job to respond to a lot of that. But again, it comes down to there's just so few kids that is it financially feasible to support a full-time program for a program that may or may not be used in any given month. But back to Senator Scott's issue, we do have children in our system that are also Title 25. It's an additional court support, but the end result is that we still have to go find somewhere for them to be placed.
Director Schmidt, following on that, is there a licensing type of situation where that prevents juveniles, pediatric patients, whatever we want to call them, from being, you know, in the same sort of space in some way as adults?
Madam Chairman, I don't know if certainly there's going to be safety issues. So, you know, it really comes down to what you define as shared space. You know, shared campus is different than a shared building, right? Are you sharing a cafeteria? Are you sharing those resources? It really isn't best practice to commingle, right? But is there a licensure issue in terms of having a facility on the state hospital campus? Not that I'm aware of, but that I would have to defer to the Department of Health.
Right, but you would have to have, at the very least, a separate wing that prevented, you know, adults and children from wandering into each other, and whether there would, you probably wouldn't have different, you could probably cross over the providers, although the providers might not care to, I mean, they would probably in their own mind be more specialized. Senator Scott.
Madam Chairman, question for Ms. Schmidt. Basically what you're telling us is it's the same as we see in physical medicine, ordinary medicine for the rest of us. There are certain conditions for which Wyoming simply does not have the volume for it to make any sense to have capacity in state, and we're just going to have to send out of state, and these 12 to 14 really high need kids tend to fit in that category. Is that what you're telling us?
Director?
Madam Chairman, Senator Scott, I think what I'm telling you is that there's an issue that we continually face. I think there's a policy discussion to be had about what to do about it. I do think there's pure economics, right? We just don't have enough kids to merit having a designated program unless we want to support it. And that's the bigger decision is it important for us to keep our kids in our state, to keep our kids closer to home, and to be able to I think more easily transition them through their lives with the supports that they need, knowing that we may have to pay some additional costs for it. We may have to repurpose something or build something. And I don't mean necessarily physical plant, but certainly programming would have to be built. And so it's a conversation that has come up repeatedly. And again, we have the option of just staying where we are and continuing to fight through it as those cases come to us. But I do think it's a deliberate policy decision that needs to be made. Is this where we want to be, and is this how we need to go? And financially, it may be, but certainly from a child's best interest standpoint, I would advocate that taking a closer look to what we maybe have available in state is warranted.
Representative Larson.
Madam Chairman, follow up if I may.
Yes, excuse me, Representative Larson. Senator Scott.
Madam Chairman, but following on Director Schmidt's comment, is there also a medical issue beyond the economics that these kids need specialized treatment, that means specialized professionals, and needs in the physical medicine area, you often find you have to have a team has to have a certain volume, or they lose their ability to stay in practice. Are we seeing some of that with these very high need kids that we simply don't have the volume to be medically safe, even if we had the facility?
Director.
Chairman Wilson, Senator Scott, a lot of these children don't have the physical medical issues. I think the medical fragility that you're speaking to. And in terms of programmatic support, I don't know what the licensure or the credentialing would be in order to understand what the ongoing education. So to your point, that specialization that sometimes requires a set amount of hours of working in that area and education. We haven't dug that far to know, what with a child psychiatrist, for example, what would they need to have? What kind of volume would they need to serve in order to keep on top of best practice and evolving medicine? So I really can't answer that question.
Representative Larson.
Thank you, Madam Chairman. And so if I may put on yet another hat in comment from my time as the chairman of the State Health Facility Task Force and the construction we have going on at the State Hospital and Life Resource Center, and also coming back to some discussion on why with adolescents on where they go. And one of the biggest challenges is unless we create a different wing and do as you suggested, but as we currently exist at the State Hospital Life Resource Center, one of the challenges with putting an adolescent there is, as you pointed out, segregation from the adult population. And then we also have to make sure that we provide education to those kids. So at the Life Resource Center, if we bring an adolescent and we put it in who may have developmental or intellectual disabilities, and that's too acute for a PRTF, and he goes there, then at the BOCES facility, he's receiving an educational component. At the Life Resource Center, it's not set up to do that. That becomes in violation of our licensure, and those advocate groups would look at that as an institutionalized setting and inappropriate. And the same thing would be in play if they went to the state hospital as it currently sits. Now, this whole where do you put them thing becomes even a more complex thing. So you recall that we, as we finish up the Life Resource Center, we'll have a number of skills nursing facilities that we take the hard to place or dual diagnosed people that had been occupying some of the beds at the state hospital and bring them to the Life Resource Center on part of that campus. So you've got the intellectual population at Life Resource Center, which is getting reimbursed by Medicaid, and then we're bringing in a mentally people whose primary diagnosis is that of mental illness onto the campus. And one of the challenges is, and this is a federal issue that we're trying to deal with, is that if that overall population of mentally ill exceed 50%, then the whole campus would be considered an institution for mental disease, and we would lose that reimbursement of Medicaid for those folks at the WLRC who are developmentally or intellectually disabled. And so there's a juggling act that goes there, and we're trying to resolve that. And so when we start playing with this adolescent population and using a state facility, I'm just throwing out that these are there's just these little complexities that we're dealing with. Shifting gears just a little bit, kind of to what Senator Schuler points out, is we will have, as you look at a state facility, regardless of where it is you choose to put that, of course, the initial investment of that are your physical assets. Where do we build it and how do we do it? Do we have buildings at Evanston that could be put? Do we have buildings at the Life Resource Center where we could do that? And I think the answer to that is yes in both cases. And which ones of those would be most appropriate for adolescents? I would only tell you that the cottages at the Life Resource Center that will become vacant as they move into the new cottages are hardened, meaning they're built for psychiatric care, and they're smaller cottages than what we have in place in Evanston. So we've got cottages that'll handle from 1 to 5 people in a cottage, and so we may have the potential. And in both places, you have a facility that is secure and has staff in place. Do we have to address the ongoing costs of operation and maintenance that might be associated with expanding the program? Of course, but I think that there's some, in this situation, we are in we have a great opportunity at probably as minimal a cost as we'll ever have of creating a program to address these acute psychiatric adolescents that perhaps would otherwise need to go out of state. And I think that, and I agree with Director Schmidt, that this is the time, and particularly this committee will be driving that bus to look at that and say, do we slip this component into that overall discussion as a safety net for Wyoming citizens, and have that if we only have say a dozen or so of those at any one time, I think that we have the assets in place to do that. It's just a matter of designing the program, which a large component of that is the educational program. Was that provided by the home district, the local district, or how, and move that forward? So that'll be part of the discussion that we have in the subcommittee moving forward, and certainly is one that we've been having with the executive branch, and this is being kicked around. So I think that your timing on talking about on this issue is exceptional. Thank you.
Representative Hallinan.
Thank you, Madam Chairman. I think one of the issues that's brought up is the fact that these people are going to be taken care of in state so they can be near family. Well, I think that that's not really the case say in Gillette, we'd be a lot closer to Billings or to Rapid City than we would be to Evanston. So I don't really think that we need to look at things simply at being in state. In state may not be good for families. Maybe better that we would be able to go out of state. So I think that's an issue that we ought to look at also in addressing this problem.
Very good. Okay, committee, unless there's other urgent, I mean, we don't have a conclusion to this topic. This was mainly informational. I think we need to let it percolate a bit more. I don't think it's going to be resolved immediately, but I think we have received a lot of information. I'm about ready to wrap. Oh, wait, I've almost forgot LSO here. Elizabeth's been just waiting to give this summary of behavioral health. You know, I would really like to keep on going. It would be so great if we could actually be done by 12. LSO did produce for us a summary of the programming and the statutes and the funding. It was kind of lengthy and thick, and I have asked LSO to just briefly go over that so that if you haven't had a chance to look at it yet, at least you know what is there. But I think we are going to need to, you need to take that. What I'm going to actually do with mine, and I haven't done it yet, is kind of draw myself up a pie chart or something like that to really put that in some sort of visual information. And I think we need to work on that. And so we're not going to, I don't think we have anywhere to go with that specifically now. We're just going to have to take all of today's material, I think, and contemplate it in our own time. But so we'll hear from LSO on that summary, and then we will have public comment on the mental health issue before we have a really brief discussion on the psychology compact. Okay. Here you go.
Good morning, Chairman, members of the committee. My name is Elizabeth Martineau with the Legislative Service Office Budget Fiscal Division. At the request of the chairman, as you know, we developed this memo that's in your packet. If you're on the web, it's meeting materials item 14-01. And if you're using your PDF version, it is page 75 in that large document. In the interest of time, I've condensed my presentation down to just kind of a few highlights I think are important as you review that document. There are essentially two parts to this document for your consideration. First and foremost, in the first part, which is a 7-page memo from us, we identified 14 programs that relate to behavioral health or prevention programming in 3 different agencies. The total from all sources of funding in all 3 of those agencies was about $288 million, with approximately $196 million of that being general funds. We just wanted you to know those numbers represent the 21-22 appropriations and does not take into consideration any of those potential budget reductions, because as you were aware, those are not yet available. So this is what we had anticipated based on the budget bill. Following table 1 on that last page, you have a list of other behavioral health or prevention programming components. They weren't really units on their own. The second part of this entire memo is attachment A. We used attachment A kind of as our guide when we identified those 14 programs originally. Attachment A, for those who may not know, was a memo we originally provided to Joint Labor in May of 2018. And it provides a historical summary from 2004 to 2018 of all mental health and substance use funding. I intend to update attachment A at some point in the near future to include the 2019 and 2020 session data as well. I'm hoping to have that ready for you guys for your October meeting, just kind of as an aside, so you have that information. To assist as you go through our 7 pages, we just wanted to point out kind of the key features on each of those tables in case you had any questions to kind of help you out. First and foremost, we provided you each with the statutory authority, be that a federal law or session law or some kind of reference for you within statute. Right next to that, we provided you with the appropriation by funding source. And then right below the funding source, we wanted to provide you some additional context to kind of see how these programs fit into the broader agency budgets. So what you actually see, those percentages represent that by funding source, that total against the whole agency. So for example, in that very first table, number 1 for the substance abuse and tobacco prevention, that other funds represents 4.4% of the total Department of Health's other funds. So that kind of may help you to gauge as you're going down through kind of how big these programs are within their agencies. Finally, at the very bottom of that, you'll see a very brief program description. We just want to give you kind of the highlights. Again, most of this information comes from the 2021 budget requests. So if you want to see any more details, you might be able to pop into the budget books and see these individual programs. I would note just briefly in closing, because this is only a very high level summary document, we did not delve too deeply into any one of these single programs. So should you have any specific questions, if you need any additional information on a certain program, or if you would like to see a similar presentation for a program we didn't even identify, we are more than happy to conduct that necessary follow-up and report back once we have that. As an aside, I would also point out, as requested, that very first page includes at the very bottom of number 1, the 2020 session law footnote for the prevention services that Chairman Wilson had asked us to include. That is a very brief overview of this document. Should you have any questions, please let me know.
Elizabeth, it's a great collection of information, which I have not had time to play with as much as I would like. Perhaps everyone else has done better than I. I think, committee, what I'm personally planning to do, and if I do it first, I'll share it with you. If you do it first, then you can share it with the rest of us. I think I'm going to do up some sort of pie chart type of thing of, you know, outpatient mental health, inpatient mental health, outpatient substance abuse, pediatric. I mean, I'm not sure all the categories and whatnot, but I feel like I need a visual aid for this. Any questions for Elizabeth or comments as far as that gathering of information?
Ma'am, I would also offer, if you would like, LSO would be more than happy to do those charts. If you had any ideas, since we do have the back end data, I'd be more than happy to provide anything or, you know, put the data in any way you wish for presentation in October.
It might take me a little while of playing with it before I decide what I want. I think, committee, you know, you're all very aware of the budget situation in the state. And I think I really feel like one of our roles as a committee is to help our colleagues understand what it is that we're doing or trying to do with our funds. You know, it would be wonderful if we could just fling ourselves on the grenade and say everything that we're doing now is great and you can't touch any of it. But that's not realistic. But I think we also need to make sure, just policy-wise and as a committee, to be a resource to understand what is going on across the state, not just state programs, but in services by other providers to the communities, and try to figure out what it is we're doing, where we've got too many silos, what could be done differently or more efficiently, what are the things that are vital to keep. You know, if we don't have a feel for that and an understanding of that, we surely can't expect the rest of the legislature to. So that's sort of my little remark. Senator Scott.
Madam Chairman, in addition to that, I think it's incumbent on us as a committee to be alert for places where if we change something, we could get the needed job done cheaper or find a non-state, non-general fund source, as we were doing with the bill we requested in the ambulance area to get that extra Medicaid reimbursement for them that wasn't going to cost us any general fund. If we see opportunities like that, then we've got something we bring a committee bill. I don't see any right now, but I would hope our subcommittee with joint appropriations could be particularly alert if there are some opportunities there. That's something that should be a passable bill in this coming session.
Okay. Well, I think we have some more of our own homework here because in some ways the analysis of this isn't something that is really works well in a Zoom meeting. We need to just go home and spend a lot of time reviewing it, I think. Elizabeth, who have we got in the waiting room for mental health comments?
Ma'am, I show that we have 3 individuals in the waiting room to provide public comments on this topic, so we will let them in at this time. It looks like it might be Ms. Cheryl Forland from Course Corrections, Ms. Somerville, as well as Mr. Frank.
All right.
I will note, ma'am, Mr. Frank may be on a phone.
Is he the 2485?
Yes, ma'am.
Okay. So we've got Mr. Frank, Ms. Somerville, and who else was on for this one? I see someone connecting to audio by the back of their chair. I'm not sure who that is. Ms. Somerville, I'll just start with you. I can see your face, so.
Thank you, Madam Chairwoman. Again, Andy Somerville, Executive Director for WAMSAC. And I just had a couple of brief comments since I've already been able to update you guys on the suicide prevention and suicide lifeline items. To the discussion you guys had earlier on the update from Representative Larson on Title 25, I just want to let this committee know that the community mental health centers are working with that county attorneys group right now. There was a draft presented yesterday, but that draft still needs some work. Specifically, Representative Larson mentioned clinical definitions for serious mental illness, making sure that they're clinically relevant. We're working on that right now and hope to have that completely fine-tuned and ready to go to take that back to judiciary in October. I believe they meet on Halloween, if my memory serves right. So we are working on that. I'm happy to answer any questions about that process if you have any for the community mental health centers. And then also, just to let you know, we're also at the table. Several of our centers are in conversations as stakeholders with DFS related to your previous conversation. And in terms of what those options might be for those community mental health centers that may have capacity and interest in trying to provide some additional juvenile services. So with that, I'd stand for any questions.
Great. Any questions for Ms. Somerville? Okay, thanks so much.
Thank you, Madam Chairman.
Mr. Frank, is that you on phone number ending in 2485? Mr.
Yes, Madam Chair, can you hear me?
I can hear you.
Thank you. Madam Chair, Mr. Chairman, my name is Frank Craig. I've been working 22 years in the criminal justice system, delivering substance use disorder treatment. I'm the state director for Gateway Foundation. I'm also the president for Wyoming Association of Addiction Professionals. My comments are regarding Representative Larson's report on the Joint Subcommittee on Mental Health and Substance Abuse, and in particular regarding special populations for criminal justice involved clients that are being served. Just to update on some of the action that's taken from identified issues from the CSG recommendations. There are some focus groups that are taking place with the Department of Corrections, with parole, institutional contractors of services provided to the DOC, and then the community providers with WAMSAC. We're looking at the discussion for continuum of care, in particular, being able to provide kind of a warm handoff for institutional participants in programming that are being released and discharged out into the programs in the communities. Some of those issues we're looking at is how we can better share personal health information to be able to provide what has been going on with treatment in regards to that inmate and their continued needs as they're stepping out into the community. The other issue specifically deals with how Wyoming is an open access state, meaning it's kind of a first come, first serve for individuals entering into or seeking community treatment. What this means for institutional population, if they're released and they get out, they go to the community, and we're working to setting them up with appointments. But if there's not a space available, they could be waiting sometimes up to 6 weeks before they're actually seen. And what we know from research is if they're not plugged in immediately into services within like the first week, that's when relapses start occurring. We've made some really good progress with that too, working with WANSAC and with those community providers to try to expedite those individuals coming out to be able to get into those treatment and start accessing treatment quicker. In regards to House Bill 31, this is also things that were identified in House Bill 31 attempting to address some of those issues. There is an oversight department that's been set up. If I understand from yesterday's Judiciary Committee from the DOC's report that that's actually working in place now. I think by October they said they would have that department set up. It's just simply kind of an oversight to ensure quality service being provided by all that are contracted. Also, there's going to be some training conducted for statewide assessors. That was another issue that CSG noticed, is that there was a variety of different ways of interpreting assessments for criminally justice involved participants. So that training is being set up. I think it may be happening after October as well. Just very briefly, Madam Chair and committee, what I see as contributing to the CSG identified shortfalls still points to how the Multidisciplinary Mental Health Board regards what is necessary and qualifies mental health professionals to practice substance use disorder in Wyoming. Current rules set in place for SUD professional certifications and licensure requires very specific college-level courses in SUD and SUD counseling, which are not required by national standards. Yet, other mental health professionals whose certification and licensure do not require the same SUD formal education are still allowed to practice the same SUD therapy. Additionally, currently our state does not recognize internationally recognized certifications specifically designed to address not only SUD treatment, but in conjunction with criminal justice populations. Until we can get these requirements and expectations for anyone practicing SUD in Wyoming resolved, we will likely continue to still see issues just like the CSG has identified. And with that, I would stand for any questions.
Okay, I'm especially glad to hear about your involvement with the continuum of care discussion, and it's good to see that some work continues in the midst of COVID. I'm glad to hear of that. Yes, the licensure things, we are aware of them certainly, and we'll just keep poking away, I guess. Does anyone have any questions for Mr. Craig? Okay, thanks very much.
Thank you.
Course corrections, your screen says. I recognize you, but I forgot your name. So if you'll introduce yourself again.
Thank you, Madam Chair. My name is Cheryl Foland, and I'm a licensed clinical social worker practicing in Rawlins, and also with the Wyoming Association of Addictions Professionals, their legislative advocate. I wanted to just very quickly talk about and greatly appreciate Representative Clem's presentation this morning on the gaps that we find. And one of the challenges that was not actually recognized that is I believe, very important from a practice perspective is that when a private practice provider is attempting to place someone not in DFS custody, into one of the other beds, specifically the PRTF, the psychiatric evaluation is stated that it has to be by a board certified pediatric psychiatrist. We have 2 in the state, as I have on my list at the moment. That is a challenge. DFS does have a contract with, I believe it's the University of Washington's mental health group who can provide that, but you can only get that evaluation if your client is in DFS custody. So it's an immense amount of money, time, and effort for parents who don't usually have $3,000 or $4,000 to pay for a thorough evaluation like that. And if we are lucky enough to be able to get in to see Dr. Brown up at WBI, sometimes there's a 4 to 6 week wait list to see him. So we have children who desperately need to be placed in those higher levels of care, and our hands are tied. The parents become very frustrated, and they may or may not be able to place them in the crisis centers, depending on where you are within the state. So that gap, I just wanted the committee to realize that it's not just that it's a psychiatric evaluation, it's the specificity of the type of person who can do the evaluation. And that is a hindrance for many families here in Wyoming who desperately need to be able to advance the care for their children. And for that, I stand with any questions.
So whose requirement is it that it has to be a board certified pediatric psychiatrist? Is it the PRTF or the insurer, or whose requirement is that?
Yes, to all of the above. Specifically, if the parents are on Medicaid, it has to, I've been able with some private insurers to have a psychiatric doctor, nurse practitioner be able to provide that evaluation. But in all situations with Medicaid, it has to be a board certified pediatric psychiatrist.
Do we still have anyone from the Department of Health on? While we're scrounging through the hallways of the Zoom land, Representative Clem?
Yeah, thank you, Madam Chairman. I'm thrilled that you brought that up. And yeah, I remember years ago, this was an issue and kind of forgot about it till you raised it. I wonder, and I guess it would be helpful if we did have someone from the Department of Health or someone who could answer this, or perhaps DFS. I don't know if they would know, but I'm wondering if there is anything that we can do legislatively to correct that. And of course, we'd have to be very crafty in how we do that. But I guess I don't know. The question that I have for you is this: it would be helpful if we could expand these who can do these evaluations. I don't know. You have to tell me here. For instance, could a board certified psychologist be able to administer something like this? I don't know. I guess if you could help me out there, that would be appreciated. Thank you.
Ms. Poland.
Thank you, Madam Chair, Representative Clem. Yes, I do believe that a board certified psychologist would be able to do the evaluation, or even a psychiatric nurse practitioner. The psychiatrist brings in the level from a medical perspective. And if we do already have a primary care physician evaluating them from a medical perspective, the next step would be to go to a psychologist who's doing those evaluations from the mental health side.
Yeah, I think evidently we don't have any Department of Health people here. We can communicate about that because, of course, it's possible that it's a federal requirement that's funneled through Medicaid. I mean, we don't know. Representative Clem, did you have a follow-up?
And just to follow, I'm just thinking this through, why a psychiatrist and not a psychologist? And I think you alluded to this a little bit. It's the medical necessity, right? Because PRTFs are considered to be a mental hospital of sorts. And so there has to be that level of medical necessity, and they do ongoing evaluations even while in a PRTF to make sure that child still reaches that threshold. And when they don't, they're not, they move quickly to transition the child out of that facility. And so that might be it, because a psychiatrist is a medical doctor. And so maybe that's why. I wonder if there's other ways that we could look around that, perhaps in conjunction with a pediatric doctor and a psychologist. I don't know. That'd be worth exploring, I think, though, in order to try to bridge that gap.
Yeah, I'll follow up with the Medicaid program on that and find out just the basis of the rule. Anything else, Ms. Boland?
No, thank you, Madam Chair, and thank you, committee, for the opportunity to speak with you today.
Thanks very much. Okay. Oh, look, guys, we've got 14 minutes left. I think we can do it. Okay, the next lineup is I see Mr. Hackman is on, and we're going to hear, I believe, about the psychology compact status. And I see there are a few other people in the room, so we'll get through everybody. Mr. Hackman, thanks for, have you been here all day? You can't hear me. Good morning, Mr. Hackman. Thank you for agreeing to come and give us a little report. Your email was sufficient, but I just felt that because there was sort of a level of public interest that it would be good to hear that just restated from your point of view. So just go ahead and tell us where we're at with the SIPAC.
Good morning, Madam Chairman and members of the committee, Dr. Hollis Hackman, Wyoming Psychological Association. I'm their legislative chair and their volunteer lobbyist. So Senate File 37, you're familiar with from the last session. There was not a real significant amount of opposition to that bill when we started with the process. We've always had some in our membership that were opposed, but their opposition and their group expanded with time. And so as the session progressed, the opposition, folks that don't like this one-size-fits-all federal or national model which is SIPAC, essentially contributed to the process getting halted, and the bill never got to the House. And so since that time, we've worked with our membership, polling our membership to figure out what the desires of the membership are. We had a survey in July, and of the 30 folks that responded to our survey, and that's out of a total membership of around 100, which isn't a bad survey response, about 30%. But amongst those folks, when asked, do they want an interjurisdictional compact at all, the majority said that they did. 80% of the respondents said, yes, we're not opposed to a compact. We want a compact. When asked what kind of compact they would like, SIPAC versus another model, which I'll talk about in a moment, which is more of a regional kind of a compact, the membership was essentially split. So I'm, as the representative of the organization, I'm trying to represent everybody here and share with you that our membership is presently split about how to proceed. I did provide some handouts early August to the LSO, just giving you an update about SIPAC nationally. I think they're up to 15 states now that have signed on to this national interjurisdictional compact model. And there's another 13 that have pending legislation. But more recently, I've got something I'm going to try to share on the screen, which is an alternative model, which is essentially a regional kind of a compact. And the opponents to SIPAC are the folks that are interested in this regional model. The regional model is still an interjurisdictional compact, and it still addresses our original goal of trying to expand access to care for people who have mental health disorders in our state. We're an underserved state by Medicaid definitions. That is, we just don't have enough psychologists to go around, and at least based on a survey back in about 2014, we had 5 counties where there was no psychologist. So these interjurisdictional compacts are promoting telepsychology or a telehealth version, and they're trying to increase access to care. I mean, that's what we're trying to do. We're trying to reduce regulatory barriers to licensure and increase access to care. So this regional compact, and if I might, Madam Chairman, if I can try to share my screen, I can get up on the screen basic outline for a regional compact. Would you like me to try to do that?
Okay, that's good. We don't need to go in probably in too much depth because it doesn't sound like it's happening between now and January.
That's correct. The bringers of the regional compact, of course, it will take some time. There's some groundwork that's been done. The board has been consulted about this. The state association, of course, has been consulted. I think there have been some states that have been reached out to in regard to the development of this, but it's definitely a work in progress. I don't know that anything will be available by January. So the bringers of the regional compact are asking for essentially a tabling of Senate File 37 and about a 24-month or so window to work with the adjoining states to get this other model up and running. So that's where we are in a nutshell. I'm happy to try to answer any questions. And I know that Dr. Ken Bell's in the waiting room. He's one of the proponents and one of the architects of the regional compact, and I'm sure he would be happy to address any questions as well.
Yeah, I think we'll actually hold off on the screen presentation just because it sounds like it's still a work in progress. Senator Bouchard, did you have a question?
Yeah, thank you, Madam Chair. You know, I'm still not ready to give up on the other bill. So I think that I don't just want to hear that we have a split. I would like to see everybody more give reasons why, specific reasons why, and come to the table and let's see if we can work those out rather than abandon what we had before and have a new plan. So, I mean, I think that there's a lot of misconceptions about what's going on with a wider scope of care that could be available. And I think, it always comes back to people putting fences up and walls, and I'd like to get past that. So I'd like to have real specific reasons of why there are objections to the previous bill. Thank you,
Well,
Madam Chair.
I think we have an objector in the waiting room, so probably we will. Any more questions for Dr. Hackman? Okay, thanks very much. We won't forget you. Keep working. And I think we may as well bring in Ken Bell, seeing he seems to be thematically next. Mr. Bell, or Dr. Bell, as you were. You're still muted. Can you unmute yourself?
Okay.
There you go.
So, Madam Chairman, Chairman Scott and committee members, thank you for your time. Most of the points that outline our opposition are included in the presentation that Dr. Hackman has for you. So, Committee Member Bouchard, if you'd like to discuss those specific concerns now, we can. Or if you want to schedule another time to do that, we can. But there are several concerns about SIPAC. So I've watched SIPAC now since 2014. I've been on the board of psychology and I followed it from its development. And they do have 15 states that are signed on, which of course means they have 35 that aren't. And there are several other people that have serious concerns about SIPAC also. So what would the committee prefer? Should we continue to discuss our specific concerns, or how can I be helpful?
So my feeling on this is, considering how the bill that we had was derailed last session, I kind of feel like that as long as the psychology community is really divided, I don't know that it's the job of the legislature to be your counselor, as it were, in this marital counseling problem. I think I kind of feel like you need to go off and bring to us something that all the members can support, because as legislators, I don't think we can just pass something that half of us think is good for you and stuff it down your throat. And I'm a little reluctant to take on that role. Senator Scott. You're still muted, Senator Scott. Maybe I can unmute him myself.
No, there we go.
Okay.
Trouble with these things. Madam Chairman, I think the best solution is if the psychological community can come to some kind of an agreement and get some kind of a compact proposal that will work. The Senate was perfectly content with SIPAC last year, but we understand what happened. I think we do need to be alert to see if there are some temporary solutions that maybe could be enacted, because we are underserved, and telepsychology is clearly what the SIPAC was aimed at, and we have some needs there to which should be solvable. So I don't have any specific proposal at this time, but I think we're going to need as a committee to be alert for the possibility of maybe some kind of a temporary fix while the psychological community is working on a more permanent solution.
If one is brought forward, we can certainly put it on an October agenda. Senator Pappas.
Yes, thank you, Madam Chair. I believe that if we leave it up to the psychological community to bring us something, you'll never see anything. It's not going to come. They're that divided, I believe. I did speak with Dr. Bell earlier prior to this meeting about his concerns. I have not looked into all of the items that he shared with me in depth yet. I did run through Senate File 37 last night a little bit, but he pointed out some other items to me today, and I will be looking at those as well. My concern with a regional compact is that it will probably end up conflicting with the national compact. And so any of the regional states any of the states surrounding us, and I think that's all the regional compact is looking at, is states surrounding us. And I'm not sure that that's necessarily wise. We may not have anything in common with Colorado, but we may have something in common with West Virginia or whatever. Anyhow, I believe that some of the concerns that are raised, I read that the information that was provided to us, and without digging into it deeply, I don't really think some of those concerns are valid. And as Senator Bouchard mentioned, you know, we do have underserved areas in the state, and it is incumbent upon us, not necessarily the professional community, to make sure that our citizens get served with these services. So while I don't disagree with you, Chairman Wilson, that we need to do something, I think it's up to us, and I don't believe it's up necessarily the professional community to take action, because you know, they have self-serving interests. Every profession does. So so I think I'm with Senator Bouchard. I think we need to keep working it, and I know they want a 24-month delay in this, but frankly, I don't think we ought to take that kind of a delay. I don't think we're going to probably have a bill for this next session, but I don't think we ought to wait 2 years.
Representative Barlow.
Thank you, Madam Chairman. So I'm confident that the professional community wants adequate and appropriate and ample services provided to the state of Wyoming. I would, so I want to make sure that I think that is very clear. They may have a different approach on how that looks and what structure there is, but I want to take a step back, because a couple of years ago, this Labor Committee, put forth a bill for telehealth medicine that gave our boards quite a bit of latitude to institute things that were appropriate for all the different healthcare professions. And so I don't think not having the SIPAC eliminates telehealth, telepsychiatry, etc. I think there's still ample opportunity for the board to participate and to undertake things. Now, can they, on behalf of Wyoming, enter a compact? I would say no. But can they facilitate telepsychiatry in a variety of forms in a corporate type manner? I think they can. So the discussion, and I'll speak a little bit to, you know, the hang up as it came last year, is when you're getting 6 emails a day and they're 3 and 3, and they're from the same 3 and 3 people, nothing wrong with those 3 people being involved or 6 people being involved, but it leaves folks at a standstill of, okay, is this ready for us to consider? Do we need to have some better understanding? So I don't think we don't have opportunities for telepsychiatry already in the state of Wyoming through our current statutory framework, and the SIPAC or REACH-PAC or whatever you want to call it, and maybe supplement them, but let's not lose fact that we already have some capacity for that. Would you agree?
Representative Barlow, I do agree. And as a matter of fact, I think I'll make myself a note here that what we could have on our October meeting is to make sure we have an understanding of what the Board of Psychology has as current telepsych tools that would enable people who wish to use telepsychology to do so. And that I'm making my October meetings now.
My apologies, Chairman, for psychology versus psychiatry. My apologies.
That's all right. I was a psychology major, so I know the difference. Do we have, is there anyone else who is in the waiting room who was here specifically for the SIPAC conversation? I think I see Ms. Foland still in the room. Did she want to talk on this?
Ma'am, as far as I'm aware, we have Andy Somerville in the meeting right now, and then we also have Mr. Ramsey Scott, who I'll admit to the room. Those are the 2 public commenters requests we had received for SIPAC specifically.
Okay, and I see Ms. Reed. Ms. Reed, are you here for this particular discussion?
Madam Chairman, I was just here to give you some information on what the board is doing in the midst of between the SIPAC I can wait or,
No, this sounds like a good time.
okay.
Let us
Thank
know.
you, Madam Chair. First, let me apologize for not introducing myself properly to you and the committee yesterday. I'm Joanne Reed. I am the manager of the A&I Professional Licensing Boards, as well as the executive director for the Board of Psychology. I just wanted to let the committee know that the Board of Psychology currently has draft rules in place where they are working to get a reciprocal license or streamlined licensing for those psychologists that are currently licensed in other jurisdictions, which will speed up the process for those individuals. And just remind the committee that the board currently has language for temporary licensure, especially during the COVID situation. It has come in very handy, and they have currently, since the emergency rules went into effect, they have issued 19 temporary licenses. So they've been successful in keeping continuity of care rolling for individuals that had to return to Wyoming from their universities and colleges and so forth. So I just wanted the committee to be aware of what the board was working on, since our board member that was here to present, he had to leave early. So he wanted me to speak in that regard. So thank you.
So you probably just heard me say that we might put a question about telepsych tools on the October meeting, but do you have anything that you want to say about that now, or would it be better to give you 10 or 15 minutes in October?
Madam Chair, I can speak to the board currently has some language. They adopted a telepsychology policy that they have on the homepage of their website. My apologies. Since the statute and the rules do not specifically say that the licensee cannot practice telepsychology, the board has given guidance in that when they do practice telepsychology, to make sure that they, again, remain within their scope of practice and the HIPAA guidelines and so on and so forth. So the board is not prohibiting telepsychology, or there's no way for the board to prohibit, since there's nothing in the statute or rules that would prohibit telepsychology in Wyoming.
Okay, well, we still might put you on for October if we compare with some of the tele capability of other licensed professionals. We'll take a look at that. Okay, any questions for Ms. Reed? Representative Sweeney.
Thank you, Madam Chairman. So when you say the board, it's the licensure board?
Ms. Reed.
Madam Chair.
Ms. Reed, go ahead.
I'm sorry, Madam Chair. My apologies, Representative Sweeney. Can you repeat that?
So when you are saying the board, you're talking about the licensure board?
Yes, sir. The Wyoming Board of Psychology. Yes.
Okay, and follow up to that.
Representative Sweeney.
So is there a problem the way the statutes related to that on substantially similar on reciprocity with the psych board?
Ms. Reed.
Madam Chairman, Representative Sweeney, I'm not exactly sure of what problem you're speaking to. You mean currently right now their rules require submission of several documents, such as experience verification, transcripts, so on and so forth. So the board has drafted some rules that would eliminate many of those requirements for individuals that are currently licensed in other states. Am I answering?
Yeah, I guess I find that interesting, but I'll leave that alone. So thank you.
So they have rules in development to eliminate some paperwork. We consider that a good thing, Ms. Reed. At least I'm pretty sure we consider it a good thing. Okay, let's see. We have, people, the little squares move around. I just saw Ramsey Scott. Ramsey, are you here to talk about the SIPAC?
I am. Thank you very much.
Okay.
Chairwoman Wilson. Ramsey Scott, Public Policy Manager with Alzheimer's Association's Wyoming chapter. Just want to encourage, we were in strong support of Senate File 37 during the most recent legislative session. Specifically for us, we see this as, we saw it as a boon, both for our caretakers who just, finding time to actually go and get therapy, counseling is hard enough as it is when you're taking care of someone. And then we're, given the nature of our state, it's sometimes hard to make that 1.5 hour, 2 hour drive to actually be able to get to that resource. So we saw this as being a way to provide care to our caregivers. Another thing is that Wyoming is essentially a geriatric psychologist desert. We don't really have anyone to provide that. And they provide patients with therapeutic techniques, including psychotherapy, cognitive behavioral therapy, remote emotional behavior therapy, and relaxation therapy, which could all benefit those living with this disease, especially as they deal with the hard ramifications of this, whether it be psychotic episodes, things like that. It can really help both them and their caregivers. Whether or not we join the SIPACT, this is something that has to be addressed, and I believe it cannot wait another 2 years for this to be addressed. I know the talk back during the session when this bill died, and then currently now, is that we could join a regional pact. And I would just point out that in the SIPACT, we already have Colorado, Nebraska, and Utah have already joined. So it is, our region's already kind of started to move that way. And there have been more states joining this as well. I'm not an expert on this, so I can't address all the specifics, but I do believe that when the Senate heard this bill in the 2020 session, that a lot of these issues that were raised were addressed. And I think, if we need to address them more, having this come back in October, having a chance for people to weigh in and for us to truly understand where maybe there might be confusion or where the conflict is, would be beneficial. I think we just can't leave it for a 100% consensus to be formed. I always reminded of the phrase, never let the perfect be the enemy of the good. And our system is in need of something dire. And so, if the state decides to move away from a SIPACT and join something else, it can't wait 3 or 4 years to the perfect solution to come. I can tell you there's no such thing as a perfect solution. There's the solution that's in front of us. And so I would hope that the committee would keep this on the radar and continue to work on this and not put it off for another 2 years, because it's hard enough as it is to go see a doctor now because of COVID. Who knows what the next situation is going to be? We need a solution. And so this solution can't take another 2 or 3 years, especially when we have a potential solution right in front of us. So I will stop rambling and stand for any questions.
Very good comments, Mr. Scott. Any questions for Mr. Scott? Okay, it looks like we have Ms. Foland in the waiting room still. Are you here?
We did not admit her on our list. We had her talking on the mental health, first.
Okay, she's just there.
We do have
see.
Andy Somerville in the meeting.
There she is. Andy, beg your pardon. I'm having trouble keeping track of everybody.
Madam Chairwoman, I just wanted to comment on the previous mental health item. I don't have any specific comments to the SIPAC. Just in general, we're supportive of anything that can help develop workforce and get us more trained providers in the state of Wyoming. I'd stand for any questions.
Questions for Ms. Somerville? Okay. Is there anyone still waiting to talk about the SIPACT?
Ma'am, I have no one else in my list.
Okay, then that topic, public comment on the SIPACT is closed. And the last item on our list, alas, we didn't make 12 o'clock, but it's always good to have goals in life. General public comment. So anyone who wants to comment on Labor Committee related topics. Do we have a few folks for that, Elizabeth?
Yes, ma'am. I will admit Christine Porter.
Okie doke. Hello, Ms. Porter. Welcome to the Labor Committee. If you'll introduce yourself, please. Yeah, you're on mute.
Sorry, my bad. I'm Christine Porter. I'm a associate professor of community and public health at the University of Wyoming. And I don't know, did your committee receive a copy of the grocery tax brief?
I don't think so. The grocery tax would probably go through the revenue committee, so we probably haven't seen it.
Well, it's also, we're also hoping to talk with them. We're mostly, we thought it was relevant for this committee. And I say we being the Wyoming Food Coalition, which has brought together food system stakeholders from across the state to launch this year. And it's relevant to health just because if I know there's discussion, there's an enormous budget gap, and a grocery tax probably would raise about 70 million a year. We, in this brief, which we'll make sure is available to you after this, myself and an economist looked at numbers, and we thought a grocery tax might bring in about 71 million, but it would grossly increase food insecurity, which of course would have a very negative health impact across the state in terms of long-term children's ability to perform in school, for example, and the chronic diseases that the stress and malnutrition cause. So ultimately it would cost the state a lot. And so on the health front, it's relevant in that case. And the brief also contains numbers for how much money could be raised with bringing our alcohol and tobacco taxes more in line with other states. That could raise, if we increased our amounts to other state taxes on those items, which of course would also be health promoting, that would raise about 78 million. And I know that with the budget gap, all things are up for grabs. But a colleague, I think, made this available to your committee, so I'll just make sure that you all get it. But on the health standpoint, we just wanted to raise some red flags about this proposition that's on the table at all. And I know everything's on the table as it should be in our circumstances, but I wanted to raise the particular costs of having a grocery tax would ultimately probably exceed the benefits to closing our budget gap. And if we were looking to do a sales tax, and all sales taxes, of course, are very regressive, right? They always hurt the poor the most proportionately, any kind of sales tax, but that we would propose an alcohol, looking at alcohol and cigarettes well before groceries, including because also that would be very fast as well, right? Instituting a brand new tax on something that's not currently taxed would take a year or two, I would think, to institute, whereas increasing an existing tax is easier and would help close the budget gap this year. So we just wanted to flag, the Wyoming Food Coalition wanted to flag that issue with this committee on the health front.
Very good information. Any questions for Ms. Porter? Representative Sweeney.
Thank you, Madam Chairman. So has your group put together any dollar amounts to food insecurity and mental health issues that are relatable? Because if a food tax, what you're saying is if a food tax is put on, we'll have all sorts of mental health issues.
And physical health
course.
issues and performance in school issues, if food insecurity increases. Those are, economists in theory can change anything into a dollar amount, but there's no, we and the economist I was working with couldn't find an actual, when a child is food insecure, their performance in school drops. There's a tie between performing in school and ultimate economic development for a state and for the livelihood of that child as they grow up. And likewise for the ill health of the whole family if they're suffering from food insecurity. But there's not a direct translation, in terms of dollar for dollar, but it's very clear that any kind of grocery tax is a particularly regressive tax that hurts people who are struggling the most. And a grocery tax reduces how much money poor families have to spend on actual food as opposed to paying the state in taxes. So there's not a dollar for dollar. We can do a dollar for dollar for other ways of taxing. We can know that it would make about, estimated based on grocery data I could find, it would make about 71 million. I could work with the economist and try to come up with a number, but that wouldn't be very rigorous. And those costs would be long-term, right? When the child is food insecure now, you see the costs the greatest costs are once they're an adult, right? And they don't go to college or they drop out and make less money over the course of their career. We could do some
Madam Chairman, we'll see her Monday or Tuesday of next week. So I'll take it up with.
Oh, in the Revenue Committee?
Yeah.
Representative Clem.
Thank you, Madam Chairman. I think this is, I'm glad you're thinking about this. I guess my request is this, and whether it's brought up at a general public comment at our next meeting or in revenue, I think you're on to something. Of course, we've seen that even with COVID. Of course, a lot of food programs out there because we know of the detrimental effects that can come, psychological and physical effects, namely with children. And we've spent a lot of time talking about children this morning. For those of you familiar, it's been referenced either yesterday or today about Maslow's hierarchy of needs, essentially kind of a pyramid, and some of those basic needs like food and shelter are extremely important and really compound problems psychologically, physiologically. So anyway, I appreciate you bringing this up. I also appreciate you bringing a solution. You just weren't no new taxes. And I like the idea of raising alcohol and particularly cigarette taxes, sin taxes, as they say, but I think that's at least the solution. And so I appreciate the willingness to come forward. I would like to see more information and have this fleshed out a little bit more. It's nice to have some of that third-hand information. Of course, we get things from the state and we get our own numbers from our own professionals, but it would be very helpful to see these things from the private sector as well. So thank you. I commend you for doing that and raising the issue. Thank you, Madam Chairman.
I do see that we have, it looks to me like LSO has just sent out the flyer that Ms. Porter was holding up. The top of the page looks the same, so I'm not taking time to read it now, but we'll add that to our list. Thank you very much for coming in, Ms. Porter. We appreciate your input on that.
Thanks so much.
Elizabeth, was there someone else in the lobby?
Yes,
waiting
ma'am.
room? Okay.
The last individual we have is Miss Cartwright. We'll let her in right now.
All righty. Hello, Ms. Cartwright, how are you? We see your face, but we're not hearing you yet. Okay, are you ready? Come on in, Ms. Cartwright.
Good afternoon, Chairman Wilson and members of the committee. I'm Jan Cartwright. I'm the Executive Director of the Wyoming Primary Care Association. Thank you so much for this opportunity to make some comments about Medicaid expansion. I will briefly state the reasons for bringing this to the attention of the committee today. First, new information has been shared with the committee regarding the value and impact of community health centers in Wyoming. As you know, community health centers, also known as federally qualified health centers, receive no state funds, but provide 323 health center jobs in the state and $41 million in direct health center funding. They provided primary care and other services to 39,000 people in 2019, including almost 1,300 veterans and 2,900 patients who receive behavioral health care. Even more important is the savings to the system. This includes 24% lower costs for health center Medicaid patients that parlays into $15 million in savings to Wyoming Medicaid in 2019. However, 83% of the health center population is low income. That is why Medicaid expansion would be an important sustaining factor for health centers, which will continue to provide care to Wyoming residents regardless of their ability to pay for those services. Speaking on behalf of the CEOs of the health centers, we appreciate the thoughtfulness and work that legislators are committing to the current COVID and economic crises. However, we also have an eye to all of the unemployed Wyoming residents who need a safety net. Medicaid expansion provides health insurance that is that safety net. Finally, many of those jobless people will not qualify for Medicaid once other benefits run out, even if their income is zero, if they do not have dependent children in that home. And I would also just add one more note. Most of the issues that this committee has tackled over 2 days would be made better and funding would be made more available if Medicaid were expanded. Thank you, Madam Chairman.
Thank you, Ms. Cartwright. Any questions for Ms. Cartwright? Evidently not at this time, but thank you very much.
Thank you.
Okay, committee. So we're just about ready to close up shop here for the day. Back some weeks ago, maybe a month ago, I guess we sent out an inquiry about not trying to have 2 full days now because we saved one from May. And so based on the best scheduling for the most people, Senator Scott and I have scheduled a meeting for October 5th and 6th. That's a Monday, Tuesday, and we'll aim for 1.5 days again like this one. It just seems, I think that just Zooming for, like 10 hours one day and 10 the next is just, I don't feel like we get the best done. So we'll aim for about 1.5 days. Subjects that would be on there, we'll of course be putting that together, but there's a number of things that we want to circle back, maybe hearing about some of the telepsych. Our intention originally for August had been to have after action report from the agencies on COVID. Seeing as we aren't really after the action yet, maybe we'll be able to do that for October. We will have, so a couple of the committee bills that we had wanted to maybe tweak that we talked about yesterday morning, the health centers, the parity, and then the upper payment limit, we'll have those on the agenda. The first 2, of course, just need maybe a little tweaking. The upper payment limit will actually have a bill for our review. We'll have the final report from the pharmaceutical study. We may have to make some evaluation of where we're at with budget cuts, just other progress. As things come to your mind, if that's by no means a complete list, just kind of a quick review. But if there are things that come to your mind, feel free to email me. We really, because of the short timing between the beginning of October and the already scheduled November meeting, it would be very difficult to ask LSO to draft significant legislation from scratch based on our thoughts and scribblings in October. So we really won't have time to come up with something brand new those days in October, I don't think. But obviously, if there are thoughts ahead that are pertinent to our assigned topics, check with me or Senator Scott on that. Does anyone have any particular comments before we adjourn? Senator Scott.
Madam Chairman, on the October meeting, one thing that I've been a little concerned about, have we confirmed that we can do that within our budget and within the constraints from Management Council without jeopardizing the November meeting?
Chairman Scott, I don't have a notarized paper from LSO, but in discussion with the LSO staff, I brought that up several times, and perhaps we will let Mr. Brody or Mr. Shaw speak for themselves, but I got the impression that we're good to go, but it would be nice to hear it from them, I guess.
Madam Chair,
Brody.
this is, sorry, John, I'll let you go.
Oh, Madam Chairman, Ian and I are probably just going to comment with the same thing, in that we have kind of spoken with the director of LSO and are going to coordinate efforts with our budgeting folks. But given the savings that are incurred as a result of these Zoom platform meetings, there's a high confidence on LSO's side that no meeting is going to be jeopardized as a result of the October meeting. I don't know if Ian wants to add anything more to that, but.
Ian?
Madam Chairman, thank you. I know nothing more to add. I did have a specific discussion with Director Obrecht about that issue. He saw no problems. I do have to say we haven't run it past Management Council. We could do that if that's what you wish to do, but I had talked to Director Obrecht about it. He didn't foresee any problems.
Madam Chairman.
Senator Scott.
Maybe Representative Barlow can give us a little guidance. The only fear I have at this point would be Management Council saying, look, we gave you so many days and you've used them and we're going to just pocket the savings and forget about your November meeting. I don't think they would do that, but given the circumstances, I'm just a little nervous and we want to make sure.
Representative Barlow.
So, Madam Chairman, I don't think Management Council is going to have any qualms about a committee wanting to do more good work within their budget. But I think it's perfectly appropriate if the chairman want to have staff draft a quick letter just to notify Management Council that that's their intention, and that if Management Council has any concern about that, to engage the chairman and learn more. So I think giving them notice would be fine. I wouldn't ask for permission, just saying. I just let them know that we believe it's within our budget and we'd like to continue on this route. Thank you, Madam Chairman.
Very good. So Mr. Co-Chairman, anyone on LSO who drafts these things, I think therefore, if we write a letter, dear Management Council, we have our 6 days, and instead of using them 2, 2, and 2, we're using them 1, 1.5, 1.5, and 2, and believe this will be under budget. Best regards.
Yeah.
Grace and peace unto you. Signed,
yeah.
Chairman Scott and Wilson.
Yeah,
What do you think?
Madam Chairman, I think that's a wise strategy that Representative Barlow has given us, and I think that's the best way to handle it. I think if we take even that minor precaution, we won't have any trouble.
Very good. Can we have a letter along those lines?
We'll get that done.
Representative Clem, do you have a?
No, I just more of a query. Do we know if we're going to still pursue perhaps a second special session? I don't know if anybody's heard, and so I thought this is as good as any. And then I guess the second thing is more of a request, and I don't want to open up this for a lot of discussion. It could probably be settled at our October meeting, but I guess more of a request on my part is I would like to, if at all possible, have a physical November meeting. I guess kind of selfish on my part, but I'd like to see people before at least I exit the legislature. So, but anyway, that's a small request on my part, but more so I'm concerned about the special session if we're considering that still.
Before probably Representative Barlow knows the most, but Representative Clem, I will just say that knowing you, I'm sure this will not be the last that we see of you regardless. Go ahead, Representative Barlow, do you have any insights for us?
I'll take those actually 2 inquiries in reverse order. I think that the budget is impacted by whether we meet physically or remotely. So if the chairman are considering a in-person meeting, that needs to be a part of the discussion you have with LSO about the potential impacts of the October meeting on the overall committee budget. I just throw that out there as a suggestion to keep in mind. I think that the remote meetings are running an average cost of 30% of a physical meeting. That's why we have more latitude in our budget to add days. And maybe I'm wrong on the percentage, but it's considerably less. And I can't speak for Management Council because Management Council hasn't taken up, at least in whole, the discussion about a second or a subsequent special session. I would say there are certainly folks are interested. If there's something that we need to do that is special, particularly in response to a federal action, either extending timelines or adding additional funds or et cetera. But since we're not getting that guidance from the federal government, as you will note that we're not getting much of anything maybe out of the federal government right now at our Congress, I don't know that the likelihood is high, but certainly in speaking with Speaker Harshman, who's chairman of Management Council, we're open to it if there's something special we can do on behalf of the state of Wyoming. So I don't see any dates being proposed. We're still waiting to see what actions we could actually take that would be meaningful. So thank you, Chair.
Thank you. Senator Scott, did you have a follow-up?
Yeah, two points, Madam Chairman, on the physical meeting issue. And frankly, I would prefer those. I think we do better work. There's a lot more interaction that's possible in a physical meeting than's possible over this. Although, again, I wanted to thank you, Madam Chairman, for chairing these. I just don't have access to the necessary technology. But it's the in-person meeting is better, but I'm going to be skeptical that it would be safe. And I know, just on a personal note, my doctor was very firm with me that I should not be exposed to the COVID virus. And so I would have safety concerns on a physical meeting in November, unless the situation changes in ways that it doesn't look like it's going to that fast. On bill drafts for the proposed in October and going forward to the November meeting, that is because you need to have them distributed ahead of time. You don't have the full amount of time available to the LSO to draft it. What that says to me is, if we're going to want such, one, they ought to be as simple as possible. And second, whatever members are proposing them should propose them not as a concept, but as something that they write out that can be distributed ahead, that the committee could potentially amend a bit in terms of giving instructions to LSO, so that if we did decide we need one, it would be one that they could do very rapidly, because we can't leave them to do our basic drafting homework on that. We've got to decide as a matter of substance what we want them to put in the bill, because would speed their process up to where they could do it. So I think we could do something like that, but we'd better have an idea that is thoroughly worked out and reduced to writing, so they have something solid to go from when they put it into a bill draft.
Okay, very good. Thank you. Well, thanks for everybody for being here. Thanks to all of you out there in YouTube land.
Madam Chairman.
Yes, Senator Scott.
Mr. Brody wants to
Oh,
comment.
I beg your pardon. I didn't see Mr. Brody's hand. Mr. Brody.
Yeah, Madam Chairman, I just wanted to echo Representative Barlow's comments. Our assumption for having these additional meetings was based on the premise of not having physical meetings. Certainly the cost savings through the Zoom is enabling to have these additional meetings. So if a physical meeting is being contemplated for some time in November, that will impact whether we should send a letter to Management Council, and if so, whether it should indeed be a request. So thank you, Madam Chairman.
I think Senator Scott and I will probably do a little after action report of our own at the beginning of the week or something and confirm. Okay, thanks to all for being here. I wish you all the best for the rest of your August. Representative Barlow, are you waving, or just you're cheering for the Aggies or something? Or no.
Madam Chairman, he's praying for rain. We all in the ag business need a little rain.
Rain would be good. Go home and read all of your materials, make charts about mental health, pray for rain, pray against COVID. We have a full slate. So I look forward to seeing as many of you as possible again. Email me if you have questions or comments, and we'll see you all later. Thank you. Meeting is adjourned.